Good morning, everyone. A warm welcome to the CME presented by KIMS Academics on clinical medicine. We will be having talks covering all major medical specialties by eminent speakers. With the support of everyone joining us, I'd greatly appreciate it if we could start the program by 9:15 a.m. Each session will be covered in 30 minutes, 20 minutes for the talk and 10 minutes for discussion. Our first talk is thrombocytopenia and clinical practice. I'd like to invite the speaker, Dr. Unni S. Pillai, consultant medical oncologist in Caritas. Also welcoming the chairpersons, Dr. R.N. Sharma, senior most professor and HOD in Pushpagiri Medical College, and chairperson, Dr. K. Vijay Kumar, retired professor in Kottayam Medical College.
Good morning, everybody. Very happy to be part of this CME on this pleasant morning. And I should congratulate Sadakat for making this very good CME come true. Now, thank you also for permitting me to co-chair with Professor Vijay Kumar. Now, the first talk is, as already said, thrombocytopenia. Thrombocytopenia is a very common problem. The condition spanning from most innocuous and treatable megaloblastic anemia, and at the end of the spectrum you have untreatable, dangerous malignancies presenting as thrombocytopenia. And in between you have got a lot of cause of thrombocytopenia which will, with varying prognosis and treatment aspects. There are problems encountered by physicians, general practitioners as well as specialists. How to go about, we'll definitely have a panoramic approach after the talk. I'll just give the mic to Professor Vijay Kumar for a while.
We are not wasting the time. Though the title first was clinical approach, here Dr. Unni S. Pillai is doing my approach to thrombocytopenia. It may vary from person, doctor to doctor. Okay, then. You can start.
A warm good morning to all the delegates, respected chairpersons, and also I thank Dr. Sadakatullah sir for giving me an opportunity to present. There are only 20 slides, and I'll try to restrict in 20 minutes. And please remain me at 15 minutes. I shall spare 10 minutes for discussion. So when he asked me to present this topic, I requested, please give me some other topic, like anemia or something. I'm fed up presenting this topic. But he insisted me to present this topic only. But during the, preparation time, I also learned a lot of things. So it will be a new insight for me in some of the aspects of thrombocytopenia. So it's clinical approach to thrombocytopenia. I'll tell you how I, treat thrombocytopenia patients, and the outline of talk will be like continue. Our outline of talk will be to first my objective will be to define what is thrombocytopenia. We'll see a little bit of pathophysiology of thrombocytopenia, and we'll discuss some case scenarios. This is how I outline this talk. So, not moving. Okay. So, as you all know, the normal platelet count is 1.5 to 4.5 lakhs per cubic millimeter or microliter. So, anything less than 1.5 we call thrombocytopenia. But on a clinical perspective or from a clinician's perspective, what will be more pragmatic or clinically relevant will be a platelet count of less than 100,000. So now they are going to change the definition, because a platelet count between 1 lakh to 1.5 lakh, if that is stable for at least for Next, I'm getting some sound. Can you rectify this? I'm getting some sound from the computer. So, if the blood count is between 100,000 to 150,000 per cubic millimeter, and that is stable, say, for the for the last 6 months or so, then that is normal for that patient. We need not have to spend much time and effort on that. So, a new definition, pragmatic or practically relevant definition of thrombocytopenia will be a platelet count of less than 100,000 per microliter. And how do you classify the severity of thrombocytopenia? If you look at it, a platelet count between 70 to 100,000 is okay, because that is not going to produce any major bleed, and you can go ahead and do any procedure if the platelet count is more than 70,000, including neurosurgical procedure. So a platelet count between 70 to 100,000 is, we are going to call them as a mild thrombocytopenia, and may not be clinically very relevant. When you manage a patient, a platelet count between 70 to say 20,000 is significant, and you may have to adjust the dose of many of these anticoagulants in that range, and this is what we call a moderate thrombocytopenia. And your risk of spontaneous bleed increases when your platelet is less than 20,000. You may get petechiae, cutaneous bleeds, etc. when your platelet count is less than 50,000, but you are unlikely to develop any major bleed when your platelet is above 20,000. So anything less than 20,000 will take it serious thrombocytopenia. And along with that, I like to add someone with fever, 20,000 and less is significant, but someone without fever, even a platelet count of 10,000 is absolutely perfectly fine. So this is how we classify the severity of thrombocytopenia. And this is very widely circulated slide picture among all medical fraternity. I took it from the Australian General Physicians website. So if you see the pathophysiology of thrombocytopenia, it could be due to decreased production from the bone marrow, like aplastic anemia, acute leukemia, a malignancy infiltrating the marrow, tuberculosis infiltrating the marrow, chemotherapy, radiotherapy, and so many other drugs. Or it could be due to increased destruction, and the increased destruction is mostly immune. And the most commonly seen are ITPs, drug-induced, HIV, especially in the early phases of HIV, around 10% of patients will have isolated thrombocytopenia, and various other viral infections. And also you can have non-immune destruction, like disseminated intravascular coagulation, TTP, HUS, which are basically life-threatening diseases. And also you can have splenic sequestration in portal hypertension. So this is about the pathophysiology. So when someone comes to me with thrombocytopenia, my first thought will be, is it an isolated thrombocytopenia, or it associated with something else? Is there associated with other features like anemia, other cytopenias, or increase in WBC count? So my differential diagnosis varies. So if it's and you also need to take a very good history and clinical exam. You need to be extremely good physicians to correctly and rightly treat all cases of thrombocytopenia. So it's a jigsaw puzzle, and we need to do a lot of mental work to get a diagnosis and also to go about how to treat these cases. So if it's an isolated thrombocytopenia, meaning the only abnormality is thrombocytopenia, then my first thought will be whether it's a pseudo-thrombocytopenia or a true thrombocytopenia. A pseudo-thrombocytopenia means the platelet count is actually normal, but because of the anticoagulant, basically EDTA actually changes the glycoprotein, react with the glycoproteins on the surface of the platelet. It causes clumping of the platelets. The platelet count will be normal, but you'll have, on the counter you may get an abnormally low platelet value. It's called a pseudo-thrombocytopenia. So this can be avoided by taking the sample in a heparinized tube or a citrated tube, or you can do a simple peripheral smear. And this peripheral blood smear is going to be an important and most important investigative tool when we manage a case of thrombocytopenia. So do that. This is a case of this is a smear. The platelet count came as 20,000. The patient came to me, and this is I think this is a but on the smear you can see lot of clumping of platelet. This is the classical picture of what you call pseudo thrombocytopenia. And now you have n number of causes for isolated thrombocytopenia. It could be congenital also. You have many of these autosomal dominant thrombocytopenia, Bernard-Schullier syndrome, so many are there, but we are not venturing into that. Basically, this is for general physicians. I'll be confining myself to the basics of thrombocytopenia. So the most important thing which we need to understand is ITP, or immune thrombocytopenia. You can also have drug-induced thrombocytopenia, viral infection, H. pylori, everything can cause. So this is a real case. The 22-year-old female, otherwise normal, history of some viral infections, flu-like symptoms some few weeks back, is evaluated at some peripheral hospital for cutaneous bleeds, menorrhagia, and on peripheral smear, examine, and on hemogram. This is a new way of. This is how we write the hemogram. This is hemoglobin. This is WBC. This is differential, and this is the platelet. So, I'm getting this sound, lot of sound here. So if you could stop the sound on this computer, I'll be very grateful. So your hemoglobin of 12.4, WBC of 4,500 with relatively normal disease, and the platelet of 13,000. There is clinical examination is absolutely normal except for this cutaneous bleeds, petechiae, purpuras. The viral markers are normal. DCT is normal. USG abdomen is normal. H. pylori we generally do is normal, and ANA is negative. And what is your diagnosis? Please. So what is your diagnosis? This is a classical case of immune thrombocytopenia. So earlier it was idiopathic thrombocytopenia. Now that has changed. It's become immune thrombocytopenia, and we don't use the term purpura. This is only immune thrombocytopenia. And what all investigations you do? We need to do a good peripheral smear, and has to be examined by a qualified person. And that, you are looking at the morphology of RBCs, WBCs, and platelets. You have to look at whether there are blasts. And RBC is also important because in a case of, TTP, what you may get is only helmet cells or destructed RBC. So the peripheral smear was normal except for thrombocytopenia, and probably you may get some larger platelets. So an ITP is always a diagnosis of exclusion. There is no, this is the test for ITP and this is the confirmatory test for ITP. This test is not there. So this is purely clinical, and that's the beauty of general medicine. Purely clinical, and we need to exclude other causes, and can be done with very minimal investigation, which I have listed in the previous slide. And the next question is, will you do a bone marrow for a case of ITP? Floor open to the audience. Will you do? We need not have to. We need not have to do a bone marrow unless it is in a patient who is above 60 years of age. Because above 60 years of age, another diagnosis will come into the picture, that is MDS, that is myelodysplastic syndrome. And isolated thrombocytopenia might be the first sign of an early MDS. Okay. So otherwise we don't use. And how do we treat? It's very easy to treat. What I do give is pulse DEXA. We do, that is dexamethasone 40 mg for 4 days, every week for 3 weeks. And along with that, then there is 2 recent NEJM articles which says that if you use MMF, that is Celcept, mycophenolate methoctyl, along with DEXA, you are, the patient will stay in remission. The remission is defined as a platelet count of more than 30,000 for more than 6 months. The remission duration and the remission, the percentage of patients who's going for remission will be better. So this is what I generally do. Secondly, we use rituximab. It's an excellent drug. For poor patients, we generally use dapsone. I am from JIPMER. Our professor was Dr. T.K. Datta. He has published the maximum on the use of dapsone as a agent in chronic ITP, and we do get fantastic results with the dapsone, 100 mg per day, and 1,000 tablets will cost only 200 rupees. For 1,000 days of treatment, you need to spend only 200 rupees. And will you any takers of splenectomy in the current era? No. Actually, you should not do splenectomy, because in a European registry, what they found is that those who underwent splenectomy for ITP, their median survival is at least 10 years less. You are losing 10 years of your life by simply doing splenectomy. And we have multiple better agents now. You have thrombopoietin analogs like L-thrombopac, romiplastim. We have been extensively used in our OPD. And we have fantastic results. And we have so far 0 death due to ITP. We never transfuse unless there is bleeding. And the point which you need to look into all patients with ITPs, whether there is moist bleeding or not. Moist bleeding means any mucosal bleeding. If you have any mucosal bleeding, hemorrhagic bullae in the mucosa, then that's very serious. We used to give them either IVIG along with steroid, and we try to bring their platelet higher as fast as possible. So that's the take-home message on ITP. I think it's not changing now. Sorry. Now you have a drug-induced thrombocytopenia. Various mechanisms are there. Most common is quinine type. Then you have haptine-induced. You have monoclonal. This drug-induced can be very rapid when you use some drugs like abciximab, which is mostly used in cardiology, and cardiology, professor is there. He'll be able to explain more about that, and those patients will not come to us. Autoantibody induced, with that we usually seen Fiban type and immune complex type. And this was a major problem. And now this is a 65-year-old lady, postmenopausal lady, osteoporotic, had a fall and fracture neck of femur. She was admitted for surgery, and due to high risk of DVT, she was given Clexane or any kind of, say, for that matter, any kind of heparin. And baseline, her blood parameters were normal. On day 7, and this fracture is on the right side, she complained of severe and excruciating pain on her left leg. On examination, left leg was pale. The toes were going in for, necrosis, ischemia. And there was a necrosis at the site of unfractionated heparin injection site. And the Doppler showed thrombosis of the femoral arteries, and hemogram shows a hemoglobin of 8, which was normal in the initially 12. WBC is normal and a platelet count of 56,000. And what is your diagnosis? Please, come on. Residents. It's HIT. Okay, HIT is heparin-induced thrombocytopenia. Very classical presentation. Usually your platelet may not go below 50,000. And the classical 40, this is the 40. Very important. This is how classically the patient presents. And the 40 is very important. Thrombocytopenia, usually more, and this is classified. You can go back and refer. This is available in all the textbook. And if your score is more than 4, here the score is 8. If your score is more than 4, you can reasonably conclude that this is HIT. And we need to immediately stop this heparin and have to start on either some of the other newer agents like fondaparinux or rivaroxaban, dabigatran or something like that. So, and this is another very common scenario in our country. By the end of summer vacation, we all will be seeing a spike in fever cases. The 100 or 50 day per OPD will become 150 day per patients per day OPD and 200 patients per day OPD. All of them will come with fever, myalgia, rash, etc. And occasionally, and someday you may see multiple patients, sick patients with thrombocytopenia. And obviously we all know, no one misses diagnosis nowadays. This is a dengue fever. Now, this is another patient, a 35-year-old patient. I hope, how much time has left to me? Time over. So, it's a 35-year-old patient after a road traffic accident, multiple blunt injuries, fractures, and sick patient admitted in ICU, progressively became sick and intubated. Chest X-ray showing a multiple lung patches in sepsis, and not probably responding to many of our antibiotics. And blood culture is showing growing E. coli. Okay? And next day, immediately on 12 or 24 hours after intubation, you are getting a call from the ICU saying that, doctor, patient is bleeding from the nose, there is hematuria, bleeding from gums, patient bleeding from everywhere. This can also happen in an acute promyelocytic leukemia patient. We have many patients coming on Saturday, that's a Saturday evening syndrome. We call our PGC dose. They all come Saturday afternoon when we are about to go home. They'll come sick with bleeding. And your WBC is 7. This is for this patient with sepsis. WBC count is high, probably due to sepsis. And you can also have low WBC in that scenario because the bone marrow will be fatigued with the cytokine storm, and the platelet is also low. Yeah, this is important. And in this case, this is how we differentiate between the next case and this case. This PT-APTT is elevated. Fibrin degradation product is high and your fibrinogen is low. And what is the diagnosis? This is a DIC. And this is a life-threatening. These are all life-threatening situations. Now you have another patient, also my patient, a 56-year-old metastatic carcinoma breast on palliative chemotherapy with the gemcitabine. So gemcitabine came on day 7, day 8 with jaundice, anemia, bleeding, seizure, and anuria. What is your diagnosis? It's a classical case of HUS or TTP, thrombotic thrombocytopenia purpura, because seizure is also there. So when HUS, you may not get the neurological findings. In TTP, you will get the neurological finding also. These are the lab parameters. You have anemia, you have severe thrombocytopenia. Your creatine is very high. You have a lot of bilirubin is high. This might be due to the liver metastasis also. And here your DCT is negative and PT-APTT will be normal, provided the liver function is normal. Okay, liver is normally. And what you get is, this is how you differentiate between the two, the DIC and TTP. And, haptoglobulin is low. This is a classical case of TTP and urgently requires exchange transfusion. Okay. And peripheral smear is the wonderful and the most important investigation for all of us, especially in hematology. We all should know the basics of peripheral smear, how to make a peripheral smear, how to stain it, and how to look under the microscope, at least under oil immersion. So this is, here you are seeing probably no platelets. You are seeing lot of fragmented. This is the helmet cell. There are a lot of fragmented RBCs, and this is a classical case of TTP. And also you have another patient, you are coming to you with a WBC count of 1 lakh, platelet of 10,000 and hemoglobin of 7. Probably you may suspect leukemia, and this is the peripheral smear exam. You are seeing blast. And also we have so many patients. Recently also we had a patient, a 25-year-old man in a hostel, wanted to reduce his weight, so was dieting for a long time, and was getting only vegetarian food at hostel. Was because he was studying in a staying at a hostel associated with an ashram. And he came with a hemoglobin of 4, platelet of 12,000 and WBC count of 1,500. LDH was 3,500 or something. And the peripheral smear will show you this. What is this? This is a hypersegmented neutrophils, and this is vitamin B12 deficiency. So, and now the take-home message, what are the red flags in thrombocytopenia? Any mucosa bleeding, hemorrhagic bullae are very serious, and they are at high risk of intracranial bleed or visceral bleed. They need to be urgently treated. And in that scenario, you can give platelet transfusion even in ITP. Second, any blast in peripheral smear or any abnormal cells like malignant cells in peripheral smear is a red flag. A thrombocytopenia in a person above the age of 70 years need to be investigated with caution, because that may be the first sign of an MDS or even the first sign of an acute leukemia. And we are going to do a marrow examination that patient. And on peripheral smear, if you are seeing dysplastic cells, associated features which we have discussed now, fragmented cells, hypersegmented neutrophils is there. It's very easy to treat. You give vitamin B12, you give transfusion. You give WBCs, you give you give platelets, not WBC. You give platelets, you give transfusion. We might be able to save that patient. This is our emergencies. We have patients with megaloblastic anemia, came with circulatory failure, congestive cardiac failure. We have many patients comes with the diagnosis of this. All because of pancytopenia, they all suspected cancer. Came to us when we elicited history. They all say that I am vegetarian for 6 years, 7 years, and the diagnosis is then and there clinched. And all HIT is an emergency which you need to treat urgently. TTP, HUS are emergencies. And now, regarding some practical aspects, when will you do platelet transfusion? I will not do platelet transfusion for any patients with platelet count of more than 20,000. This is a statement. And I will be very angry with my PGs if they are giving platelet about 20,000, because they are precious and has to be reserved for needy patients. Unless there is a major bleed. The excluding, cutaneous bleed we are not going to do, but if there is hemorrhagic bleed, wet bleeding, or major bleeding, we do that. Anyone with a fever and platelet of less than 20,000, we do transfuse. Anyone without fever, my cutoff is 10,000, but you also wait up to 5,000. What is important is not the platelet count. It's also called, if you have a facility to look into the immature platelet fraction, that is important. If you have a very high immature platelet fraction, that indicate that there is immune destruction, but the marrow is trying to compensate for that destruction. We need not have to worry much. Those patients may not bleed much. And also this can be done in ITP also. Very good investigation in ITP also. So up to 5,000 you can wait, but generally, in today's scenario, we give up by 10,000 we give transfusion. For putting a central line, there are some spelling mistake. I don't know how come that atheist tunnel came over there. So at least that's not atheist. It's at least a platelet of 20,000 should be there. For elective, I'm sorry for that spelling mistake. For elective surgeries, a minimum platelet count should be 50,000. Elective surgery, including hip replacement, liver transplantation, kidney transplantations, your hernia repair, cesarean, whatever. If you have a platelet count of 50,000, you are absolutely safe. You are not going to get a high bleed. And for elective lumbar puncture also 50,000 is okay. But if you are going for any neurosurgical procedure or that's not vitriol, it's all autocorrect, I'm so sorry I didn't read this. Retinovitreal surgery, it should be at least 75,000 or more. With that, I thank you all for your patient listening. Thank you. And if time permits, I can take some questions.
You have all finished almost in time, but everybody should be, especially physicians, should be well aware of the red flags he had shown. And also, there may be any questions, you can ask questions. The government directive is to transfuse platelet only if the count goes below 10,000.
Yes.
That was the government order.
Yes.
Once, a few years back, there was a hue and cry. Everybody, when the platelet falls from 50,000 to 45,000,
not required.
They were all running around for platelet transfusion, demanding to the doctor, you give platelet. No. Then that time, the Kerala government had directed. Only less than 10,000 is indication.
Yes.
Right.
Less than 20,000, suppose you have an acute leukemia patient in sepsis, ventilator and with high fever running, it is 20,000. Otherwise 10,000. And ITP we don't transfuse. Even with 5,000, even with 1,000 I have not transfused. Unless there is a red flag like mucosal bleeding, we do transfuse. Otherwise, even with thousands, they won't bleed. They won't bleed. And acute thrombocytopenia patients bleed more rapidly than chronic thrombocytopenia patients.
So rapid fall is also important. Say a person,
yes.
Rapid fall in platelet, you should be skeptical.
And they say that in TTP you should not transfuse. But that is also a caveat, is that if you have a life-threatening bleed in that situation, you can transfuse in TTP also. But, rather than transfusing in TTP, your aim should be to do an exchange transfusion and remove the antibodies.
Any more from the audience? Now, just one point, talking about pseudothrombocytopenia. What are the clues? One, you change the thing to from EDTA to the heparin. Another clue is the platelet satellitism. If you look at the peripheral smear, the platelets are clumped around the WBC.
Yes.
Classical NEGM smear is there. So we also see that. That's also important. Then conditions where you have thrombocytopenia and thrombosis. Can you just highlight?
One is this HIT
syndrome.
HIT is another one. That is the only thing which I can immediately remember and tell, which we mostly see. Can also happen in acute promyelocytic leukemia. It can be there. Someone who is on L-asparaginase on ALL therapy, they can have present with thrombosis and thrombocytopenia. This is what I have seen in my practice. Not come across with any of those other, No, because platelet surface does not contain any, blood group antigens. You can transfuse any group, and why we insist on group is that sometimes this blood will be, platelet will be contaminated with a very mild quantity of RBCs. If you are having very good blood bank, and if they can give, minimize the contamination, you can transfuse. We are not giving group-specific platelet to anyone. When I request for platelet, I write any group is okay. But the blood bank shall try to give us the same group whenever possible. If that is not there, I do accept any group. But when we make SDP, and all the RBC contamination is practically zero. There won't be any RBCs in SDPs. So any group is fine. Need not be group specific.
When a platelet transfusion material is transferred to some other place, from one hospital to blood bank to another hospital, is there anything called a platelet shaker?
When they keep in the blood bank, they keep it in that shaker. But what we generally do is that we quickly get it transfused. That is what we do. There is nothing like a shaker, or we need not have to shake it while transfusing. That is not required.
Now, what about how much platelet will be elevated after one unit?
That depends upon the quality of the product, and also when was the product collected. Ideally, we have a transplant going on now. We have admitted a transplant. I'll be making platelet tomorrow. I'll be making SDP tomorrow, and I'm expecting platelet count to come down tomorrow or day after tomorrow, and I'll be transfusing immediately. So the quality of platelet will be better if you do that. Usually when we give an SDP, we are getting something like 30,000 per cubic millimeter increase in platelet. So if you wanted to do that, to make it say 10,000 to 50,000 or so, then we may have to give you 2 SDPs. When you use a pooled RDPs, which was very common some time back, they used to pool RDPs, make it into one bag, and then they used to give 4 or 5 RDPs. They pool, and then that will increase platelet by 10,000. So usually when you give 4 or 5 RDPs, platelet count will get increased by around 10,000 per cubic millimeter. That also depends upon the blood volume of the patient. That's different for pediatric patients and different for adult patients. Also varies depending on weight and all.
Thank you, Dr. Unni. We will wind up this session. If there are any other doubts, you can ask personally to him. Thank you.
Nothing. Thank you. Thank you so much.
Thank you. Inviting Dr. R.N. Sharma to present a memento to Dr. Unni S. Pillai. I'd also like to invite Dr. Keshavan to present mementos to Dr. R.N. Sharma and Dr. K. Vijay Kumar. Our next session is on approach to chest pain. I'd like to welcome the speaker, Dr. Deepak Davidson, Chief Interventional Cardiologist from Caritas, and chairpersons Dr. V.L. Jayaprakash, Emeritus Professor of Kottayam Medical College, and Dr. Praveen Jain, Interventional Cardiologist, Bharat Hospital.
Slide. Good morning, everybody. First, thanks to Sadhguru for inviting for this. Respected teachers and colleagues, the topic is very important. All we all know the importance of chest pain, especially a patient presenting with chest pain. If the diagnosis is not correct, it can be fatal. So no need to introduce the speaker.
Okay. Respected teachers, today's basically speaker, everybody knows about Deepak sir. Deepak sir is the senior consultant cardiologist in Caritas Hospital. He is well versed with all the major cardiac procedures. So, respected sir, today we would like to listen to how to evaluate chest pain in our clinical practice. So, Deepak sir.
Good morning to all of you. Thank you, GP sir and Praveen. First of all, let me take this opportunity to thank KIMS Academics as well as Dr. Sadak for the opportunity given. Over the next 20 minutes, I shall share with you. Can you please switch off this light also? Something on chest pain and approach to chest pain evaluation. If possible, can we switch off this also? If possible. Okay. Well, why is chest pain evaluation very important? As JP sir has mentioned, it could be a cardinal manifestation of a life-threatening illness. It could be a very distressing manifestation of a very trivial illness like osteochondritis. So this life-threatening illness one shouldn't be missing. It could be a myocardial infarction, it could be a pulmonary embolism, it could be pneumothorax, it could be aortic dissection. And so in these subset of patients, once we miss the diagnosis, this could cost the life of the patient. So that's the reason why evaluation of chest pain is extremely important. Now, what are the common causes of chest pain? One, it could be cardiac or it could be non-cardiac. If it's cardiac, it could be coronary or it could be non-coronary. Now, this was the ECG of a patient who was admitted with chest pain. He was a smoker. And how do we diagnose myocardial infarction in this particular patient? You could see that there is ST elevation in lead 2. You could see that there is ST elevation in AVF and 3. So you have ST elevation in 2, 3 and AVF. You tend to see some ST depression in lead 1 and AVL. So you have significant ST elevation in the inferior leads, which makes us understand that this is an infuvol myocardial infarction. Now, this was another patient who presented with chest pain. He's a smoker, diabetic. He had chest pain while at home for 3 minutes. In the casualty, he did not have chest pain, and this was the ECG taken. You could see that it's a normal ECG. Now, is he fit enough to be discharged? He had chest pain. Primarily, he's a diabetic smoker. He had chest pain at home. It lasted for 30 minutes. Presently, he's comfortable. No ECG changes. Now, what would you do? Would you send him home? Ideally, it's to be kept in mind that you need to have a troponin evaluation at the end of 6 hours. And if troponin is positive, then one needs to consider this particular patient as having an acute coronary syndrome. If troponin is negative, it's always safe to repeat the troponin value at 12 hours, provided this particular patient has multiple risk factors. Now, we know that this particular person is a smoker, diabetic. He has risk factors for developing coronary artery disease. Now, if you feel that this symptom is going to be significant, then a troponin at the end of 6 hours may not be enough. If it's normal, you need to keep him in the casualty. You need to at least admit him for 12 hours, repeat a troponin, and if this turns out to be negative, then probably you could say that this is less likely to be coronary artery disease, and it's also good to have a treadmill evaluation done at some point of time for this particular patient. Now, this particular patient, despite ECG being normal, not having chest pain, he had a repeat troponin at the end of 12 hours. It turned out to be positive, and when an angiography was done, you could see that this is the circumflex artery. There is a tight stenosis in the circumflex artery, and he underwent angioplasty for the same. Well, what are the situations where myocardial infarction could be missed in electrocardiogram? We know that when we have a significant ST elevation in the electrocardiogram, it's easy for us to make a diagnosis. Well, this was a patient who was admitted with chest pain of 30 minutes duration. He was a diabetic. Now, if you go through the ECG, you can see that there is no significant ST elevation in most of the leads, but you tend to see that there is some ST depression in V1, V2, and V3. There is ST depression. So, we tend to diagnose that this is likely to be an unstable angina. Well, we also had an echocardiographic evaluation done while the patient was in casualty. This is actually the anterior wall of the left ventricle. You could see that the anterior wall is contracting well, but if you look at the posterior wall, this is the posterior wall of the left ventricle, you could see that this particular area is not contracting well compared to all the other areas. So one could suspect that this could be a posterior wall myocardial infarction, and you could also have posterior leads electrocardiogram taken. Now you could see that in V7, V8 and all, you tend to see that there is ST elevation. These are the posterior leads. You tend to see that there is ST elevation. So you could make a diagnosis of posterior wall MI based on this ECG as well as based on the echocardiographic finding. He underwent an angiographic evaluation. You could see that his circumflex artery is totally occluded. That's the area of the circumflex artery. It's totally occluded. Underwent angioplasty, and that vessel is opened up. So a posterior wall MI, an isolated posterior wall myocardial infarction, could be misdiagnosed as having unstable angina. Now this was the ECG of the particular patient after 3 days. Well, this is another patient, 64-year-old patient admitted with chest pain and hypotension. You could see that there is no significant ST elevation in most of the leads, but in lead V1 alone you could see that there is some amount of ST elevation. But usually for making a diagnosis of myocardial infarction, you need to have at least ST elevation 2 leads. So here you see that there is ST elevation in only 1 leads. Still, that is important. You need to have a troponin evaluation. But what could be the diagnosis when you have an ST elevation in V1 alone, patient is in hypotension? You could also evaluate the right-sided leads. If you concentrate on this right-sided leads, V4R, you could see that there is ST elevation in that particular lead, which makes us understand that this particular patient is likely to have a right ventricular infarction. When echocardiogram was done, this is the left ventricle and left atrium, this is the right ventricle and right atrium. You could see that normally the right ventricle should be smaller than the left ventricle. Here you could see that the right ventricle is ballooned out compared to the left ventricle. So based on this, you could suspect that this could be a right ventricular infarction. And in V4R, if you have significant ST elevation, that clinches the diagnosis. So when you see just ST elevation in V1 alone, this could be an indicator that this particular patient is having an isolated right ventricular infarction. And when an angiography was done, you could see that it's a small right coronary artery and it is totally occluded. So we managed this particular patient conservatively. We did not have to go ahead with an angioplasty because it was a right ventricular infarction. He was managed with dual antiplatelets, anticoagulants, lot of fluids, and he settled down with that. And on discharge, the electrocardiogram was much better. Well, this is another patient who is a hypertensive who was admitted with angina and sweating. You could see that the QRS complex is wide, and this ECG, this QRS complex being wide, suggests that he's got a left bundle branch block. Now, how do we diagnose myocardial infarction when somebody's got a left bundle branch block? Because many times you do an ECG, many times in a patient with LBBB, you tend to see ST elevation in V1, V2, V3. So, you are always confused whether this particular patient has got an associated myocardial infarction, associated anti-wall myocardial infarction or not. So the easy way of identifying that is if you look at the lateral leads, if you look at lead 1 and AVL, there is ST elevation. Moreover, you can see that in the lateral leads V5 and V6 also you have ST elevation. In an isolated left bundle branch block, you wouldn't be seeing ST elevation in the lateral leads. Many times this is how the ECG would look like in the lateral leads when you have an isolated left bundle branch block. You could see that there is ST depression and T inversion in lateral leads. Now when you have ST elevation in the lateral leads also, that goes in favor of a anti-wall myocardial infarction. This particular patient underwent an angiographic evaluation. The left anterior descending artery was occluded and it was opened up, and he had a reasonably good outcome. So just to highlight the fact that every LBBB may not be an anti-wall myocardial infarction. A patient with typical chest pain, sweating, multiple risk factors, you see an LBBB, always watch carefully whether he's got an additional myocardial infarction or not. Now, this is another patient, 52-year-old, chest pain, and he was in cardiogenic shock. You do not see significant ST elevation in most of the leads, but then what is alarming over here is you tend to see lot of ST depression in most of the leads. In lead 1 AVL, in lead 2, 3 AVF, and in V1, V2, V3, V4, almost all the leads you tend to see significant ST depression, and you also see significant ST elevation in just AVR alone. This is the most dangerous electrocardiogram one could have when somebody's got a coronary artery disease. Basically, this particular patient has got global ischemia. That is what you would identify from this particular ECG, and that was the reason why he was in cardiogenic shock. You tend to see ST depression in almost all the leads, and you tend to see ST elevation in AVR alone. And when we did an echocardiogram, you could see that almost all areas of the ventricle, that's the anterior wall, septum, the lateral wall, almost all the areas of the ventricle was not contracting at all. And when he was taken to the cath lab, we found out that the left main coronary artery was totally occluded. So the left anterior descending artery was not perfused, the circumflex was not perfused, just to highlight the fact that it was global ischemia. And when we see an ECG something like this, lot of ST depression, just ST elevation in AVR alone, this is the most dangerous patient, and he needs to be immediately referred for further evaluation and probably a coronary artery bypass surgery. Now, what are the situations wherein we tend to misdiagnose myocardial infarction based on ECG when they do not have myocardial infarction? This was an young chap, left-sided chest pain, no significant risk factors, and a typical chest pain for which he had an ECG evaluation. You tend to see that there is some amount of ST elevation in V1, V2, V3. So when you have somebody who doesn't have multiple risk factors, atypical chest pain, but ECG is something suggestive of ischemia, in those particular situations, straight away do not make a diagnosis of Brugada syndrome. This was a Brugada ECG pattern, but then it's always good to have at least the troponin values done at 6 hours and an echocardiogram if possible to make sure that there is no wall motion abnormality in the anterior wall, just not to miss MI in this particular situation, because you could have these sort of STT changes in patients with myocardial infarction also. So when you see an young man, a typical chest pain, these sort of ECG changes, mostly the diagnosis is going to be a Brugada ECG pattern, but then make sure that there is no evidence, he doesn't have a myocardial infarction, he doesn't have ischemia, by doing a troponin and by doing an echocardiogram to make sure that there is no wall motion abnormality in the anterior wall. Now, this is another patient, a typical chest pain. He was a hypertensive. Just to highlight the fact that the ECG, you could see that there is evidence of significant left ventricular hypertrophy, and you could also see that there is some amount of ST elevation in V1 and V2. In every patient with significant left ventricular hypertrophy, you tend to see these sort of ST elevation in V1 and V2. Mostly make sure that, keep in mind that when you have these sort of ST elevation in V1 and V2 in severe left ventricular hypertrophy, this is a repolarization pattern, and you don't have to be worried about this, and you wouldn't have to make a diagnosis of myocardial infarction based on this ECG. Well, this is another patient, a 35-year-old smoker who had a left-sided chest pain, and this was the ECG done. You could see that there is some amount of ST elevation in V4, V5, V6, and he underwent thrombolytic therapy, and he was referred to us. When we evaluated him, the troponin was negative. Even though he had undergone thrombolytic therapy, his troponins were negative. So this particular ECG, you have a heart rate of around 60. Relative bradycardia, you tend to see an upsloping ST elevation elevation, and you also see some J waves over there. It's more in favor of an early repolarization syndrome. So when you have an ECG something like this, you have a J wave, you have a concave upward ST elevation. This goes more in favor of a early repolarization syndrome. However, as I mentioned earlier, it's always good when you think that there is an ST elevation in certain leads, do an echocardiogram if possible, see whether that particular territory is moving or not. If that particular territory is not moving, then it's ischemia. If that particular territory, if wall motion abnormality is present, then you tend to think that it's ischemia. If there is no wall motion abnormality, you understand that it's less likely to be ischemia. Moreover, because he's a smoker, also have a troponin done at least at the end of 6 hours before making a diagnosis of non-cardiac chest pain and before making a diagnosis of early repolarization syndrome. Just to highlight the fact that in early repolarization syndrome, you tend to see this sort of bradycardia, a J wave, and you tend to see an ST elevation in the lateral leads, which is usually a concave upward ST elevation. Now, this was a patient who presented with syncope and chest pain, syncope and headache in the casualty. That was the ECG taken for this particular patient while in the casualty on a busy day, and it was shown to the resident. The patient was initiated on aspirin, clopidogrel and heparin, and patient became further unconscious after 2 hours. CT revealed a subarachnoid hemorrhage. So just to highlight the fact that history taking is extremely important. Syncope and headache, it was not angina. You tend to see these sort of giant T inversions in patients with intracerebral bleed or subarachnoid hemorrhage. However, this could be also part of stress related T inversions, but when you see this sort of T inversions, always keep in mind that this could be ischemia. However, make sure that this is not ischemia related by further evaluating the troponins echocardiogram could also help you to make a diagnosis, but then history taking is extremely important in these sort of situations. And very rarely we tend to see surprises. This particular boy was an young boy seen long ago in our OPD. He presented with chest pain. It was not given a lot of importance, but then he continued to have chest pain. Because of that, he underwent an echocardiographic evaluation, and echocardiogram revealed that he had severe left ventricular dysfunction. And later on, he underwent an angiogram. You could see that there is aneurysm in the coronaries, there is stenosis in the coronary. Primarily, it was a Kawasaki disease, and later on, he underwent bypass surgery, and we lost him. Now, what are the other causes of chest pain other than myocardial infarction? It could be a non-coronary cardiac cause of chest pain. It could be musculoskeletal, pulmonary, esophageal, vascular, and rarely it could be psychological chest pain also. This is a 70-year-old patient who was in the surgical ICU, had breathlessness, had some chest pain, and this was the ECG taken. You could see that in the ECG, there is some amount of ST elevation in V1, V2, V3. The T waves are inverted. It looks as if this particular patient has got an anterior wall myocardial infarction. Troponin was done. Troponin was just positive. It was mildly positive, but then if it were to be an anterior wall myocardial infarction, you would expect significant amount of elevation of troponin, but then there was ECG suggestive of an anterior wall myocardial infarction. Troponin was borderline positive. Patient was in surgical ICU, and the clinical history probably should make us alert that this could be a Takotsubo cardiomyopathy. This could be a stress cardiomyopathy. Echocardiogram when done, you could see that there is hypokinesia, that is, this is the apical region, this is the basal part of the heart. You could see that the basal part of the heart is contracting well, however the apex is not contracting well, the apex is looking like a balloon, it's a little bit ballooned out. So this is in favor of a stress cardiomyopathy or a Takotsubo cardiomyopathy. Later on, this patient for evaluation also underwent a coronary angiogram which revealed a normal coronary. So just to highlight the fact that when you have a patient who is admitted in the ICU, if you tend to have chest pain, breathlessness, troponin borderline positive with ECG evidence of myocardial infarction, echocardiogram could make us diagnose that this could be a Takotsubo cardiomyopathy or a stress cardiomyopathy. This is primarily apical ballooning seen in the angiogram. The basal part of the heart is contracting well. This apex, it's balloons. That's why you call it a stress cardiomyopathy. Primarily, again, the Takotsubo, it's something similar to a Japanese strap. When you do an LV angiogram, the LV apex looks like a octopus strap. That's why you call it as Takotsubo cardiomyopathy or stress cardiomyopathy. Now, this particular patient was managed conservatively, and the echocardiogram became normal at the end of 7 days. And at discharge, the ECG also was normal. So it's this particular stress cardiomyopathy is being more and more recognized in the ICU. In the past, when angiography was not routinely available, we all consider these patients that have myocardial infarction, we used to treat them with aspirin, clopidogrel for long duration. Nowadays, when more and more of angiogram is being done, you tend to see that this particular patient, they tend to have normal coronaries, and in retrospective, at least you tend to make a diagnosis of Takotsubo cardiomyopathy. Well, this was an alcoholic who was admitted with chest pain. You could see that there is ST elevation in V1, lead 1 AVL. You could see that there is ST elevation in 2, 3 and AVF. You could also see that there is ST elevation in V4, V5, V6. You could see that there is ST elevation in majority of the leads. There is no significant ST depression. So you tend to see non-territorial ST elevations. And when echocardiogram was done, you could see that he's got a significant amount of pericardial collection around the heart. So he was an alcoholic. He had a pericardial collection. So the diagnosis of pericarditis was made. When liver was screened, you could see that there is a liver abscess also. That's a liver abscess which is communicating into the pericardium, and that was the reason why he had chest pain. That was the reason why he had ST. So it is primarily a case of pericarditis. Now in pericarditis, you tend to see non-territorial STT changes. You tend to see ST elevation in most of the leads, and you tend to see PR segment depression also. So when you see this sort of PR segment depression, probably one should think in terms of pericarditis in these subset of patients. You could have mild elevation of troponin in patients with pericarditis also when you have some myocardial involvement also. This is another electrocardiogram of a 24-year-old smoker who presented with chest pain. You could again see that the ECG is looking similar to the previous ECG. You tend to see ST elevation in lead 1 AVL, you tend to see ST elevation in lead 2, you tend to see ST elevation in V1, V2. So almost all the leads there is ST elevation. He was a smoker. When we did the echocardiogram, we made out that there was a mild pericardial effusion for this particular patient. He was managed conservatively, hoping that it was a viral pericarditis. He did well. He came back with a repeat episode of pericarditis almost 3 months back. Again, after 3 months, he came with a repeat episode of pericarditis. This time he was further aggressively evaluated. ANA was positive. His anti-Rho, anti-LAB and antibodies were positive. So it was primarily a case of mixed connective tissue disorder which presented with pericarditis. Well, this was another young chap who presented with atypical chest pain. You tend to see there is some ST inversion in this particular lateral leads. However, this particular T inversions were considered at that point of time as non-specific. It was told to him that you do not have any cardiac involvement. He in fact underwent a treadmill evaluation also for this sort of T inversions, and treadmill also turned out to be positive. However, a few days later he presented with these sort of small gangrenous changes on his toes. So this time it was evaluated and he had some abnormality in the Doppler. So he underwent an angiographic evaluation of the peripheral arteries, and when the angiographic evaluation of peripheral vasculature was done, he also underwent an evaluation of the coronaries because of the T inversions, and you could see that there is some luminal shadows inside the right coronary artery that was suggestive of a healed thrombus. So he had some thrombosis of the coronary artery, that was the right coronary artery. This was the left anterior descending artery. Again, in the left distal anterior descending artery also there was evidence of thrombosis. So he was further evaluated and we made out that his platelet count was 6.6 lakhs, and this platelet count was the reason why he had thrombosis of all these vessels, and presently he is under the treatment of Dr. Unni. He is doing well for the last 4 years. Now, chest pain other than myocardial infarction, it could be non-coronary cardiac, it could be musculoskeletal, or it could be traumatic. Regarding musculoskeletal, it could be cervical disc disease, it could be costochondritis, fibrositis, herpes zoster before the rash, neuropathic pain, rib fracture. There could be a lot of reasons why you could have chest pain related to musculoskeletal causes, and even trauma to the chest also can lead on to chest pain. This was a patient who had a road traffic accident 3 months ago, now presented to have nagging chest pain, mild discomfort for the last 3 months. He underwent a CT angiogram, and a CT angiogram cleans the diagnosis. He had a aneurysm in the descending thoracic aorta. You could see that there is an aneurysm, that's an outpouching in the descending thoracic aorta at that particular age, which can at particular area, it can be clearly made out over here. So finally he underwent a stent implantation over there. That was an endovascular stent implantation being done. The stent position there, you are seeing the aneurysm there, and that's the result after the stent was implanted. Well, you could have pulmonary reasons for chest pain. It could be pleuritis related, it could be pneumonia, it could be pulmonary embolism, or it could even be related to tension pneumothorax. This was a patient, an obese lady who presented with chest pain, dyspnea, her troponin was positive. So our resident made a diagnosis of acute coronary syndrome. You could see that there is T inversion in lead 2 and lead 2, 3 and AVF. So inferior leads, you could see T inversion. The troponin was positive and was made, and a diagnosis of acute coronary syndrome was made and was initiated on heparin. Now, when echocardiogram was done, you could see that the right atrium and right ventricle was significantly dilated. So when you see a patient with dilated right atrium, right ventricle, with breathlessness, always think in terms of pulmonary embolism. When you have a moderate or a severe pulmonary embolism, massive pulmonary embolism, the right atrium and right ventricle, it immediately dilates, it balloons out. So based on this particular finding, we have diagnosed many pulmonary embolism, because ECG you may not be able to clearly pick it up, but when you do an echocardiogram, if you see that the right atrium and right ventricle is dilated, always think in terms of pulmonary embolism. Go ahead with a CT angiogram to evaluate for pulmonary embolism. So after seeing this echocardiogram, the ECG was further evaluated. Now you could see that there is S1, Q3 and T3, which is more in favor of a pulmonary embolism. So you could have these sort of T inversions in anterior leads V1 to V6 in pulmonary embolism. You could have something very specific, S1, Q3, T3 in pulmonary embolism. So just to highlight the fact, the message is, when somebody comes with breathlessness and chest pain, you tend to see these sort of T inversions. Troponin positive. Troponin also can be positive because of the right ventricular strain. You could have a troponin positivity. Always having an echo will clinch the diagnosis, will make you suspect that this is likely to be a pulmonary embolism. Well, we had a pulmonary angiogram also done for this particular patient. You could see that there is huge amount of clot sitting inside the pulmonary artery, which can be appreciated in this frozen image. Patient underwent thrombolytic therapy for 48 hours, and you could see that the entire clots have disappeared. So these are the pre and post procedure images. You could see that the clot sitting there, and this is following thrombolytic therapy. It's totally disappeared. This is another patient who presented with chest pain. You could see that there is ST elevation in V1, V2, V3. He had atrial fibrillation also, was taken to the cath lab. In the cath lab, we found out that the left anterior descending artery was totally occluded. We did an angioplasty for that, but we also made out something interesting. You could see in the lung fields, the lung shadows were not seen in the lung fields at all. So we could also identify it was an antival myocardial infarction patient. Also he was a COPD patient. He also had cough and pulmonary edema. Because of the cough, he also had a pneumothorax, tension pneumothorax. So that too was identified, and he had a primary angioplasty and a ICD also implanted at that point of time. Now, regarding gastroenterology causes for chest pain, it could be GERD, gastritis, peptic ulcer, gallbladder disease, and very rarely, one shouldn't miss this particular situation. This was a 64-year-old gentleman who developed vomiting and severe chest pain immediately after a heavy meal. He collapsed. He was taken to the ER. Finally, a diagnosis was made. He had an esophageal rupture. That led to hypotension, shock, and he underwent surgical correction of that. Now, rarely vascular causes of chest pain could be dangerous for certain patient. This was a 74-year-old hypertensive patient with severe chest pain. You could see that there is ST elevation in lead 2, 3 and AVF. So that makes a diagnosis of inferior wall myocardial infarction. You could see that ST elevation is seen in lead 2, 3 and AVF. So that is inferior wall myocardial infarction. This particular patient was taken to the cath lab, and we diagnosed that it was a aortic dissection. You could see that 2 minutes. So this was a case of aortic dissection. What happened was he had a dissection involving the ascending aorta, and that's the flap seen there. You could see it in this particular image. The flap was actually extending into the right coronary artery, and that was the reason why this particular patient had an inferior wall myocardial infarction. Echocardiogram was done. There was a flap sitting inside the aorta. So I'll skip those slides and come to the last few slides. So diagnosis of aortic dissection could be easily made out with echocardiogram, provided you suspect the aortic dissection. That's the descending thoracic aorta. You have a dissection flap sitting there, and the diagnosis finally can be clinched with the help of a CT angiogram. Now, what's our job while evaluating chest pain? Identify life-threatening problems, appropriate urgent management of life-threatening problems, avoid overdiagnosis and overworkup, and avoid inadvertent discharges. So these are probably the reasons that shouldn't be missed for a chest pain problem. probably, if you miss these diagnoses, probably we might lose the patient. Once again, thanking Dr. Sadak for the opportunity given. Thank you very much.
Thank you, sir. Inviting Dr. V.L. Jayaprakash to give a memento to Dr. Deepak Davidson, and Dr. Shobana Devi Madam to give a memento to Dr. V.L. Jayaprakash and Dr. Praveen.
Thank you all. Let us, I think we are proceeding for the inaugural session, and so we will have okay. So some questions can be, Dr. Deepak has done a very elaborate coverage of all the topics with chest pain, and let us go for some queries. Sarma sir.
Thank you for the nice discussion. Just one point. You said you are highlighting the clinical scenario and history, very important, because patient subarachnoid hemorrhage is missed because of the giant TV inversion. Similarly, in dissection also, you have seen the last slide is on dissection. We had a patient about 6 months back. Patient came with central chest pain, evaluated in cardiology, emergency medicine, and admitted in Department of Medicine for 3-4 days. And they didn't take the proper history. History revealed the central chest pain, interscapular pain radiating downwards. So it is very typical. Angiogram was done, showed a typical dissection beyond left subclavian going down like this. Fortunately, celiac artery, nothing was involved, and came to the right common iliac, and the patient is subject to surgery. So this can happen. So your clinical history is very, very important, and also it is important to take the BP in both upper limbs, sometimes preferably in the lower limbs also, so that we may not miss such a dangerous condition. If you give aspirin to the patient with a dissection, what can happen? Aspirin. No, usually give aspirin clopidogrel. So I think the bleeding will continue. Number 2, the books highlight the D-dimer, dissection versus coronary. Can you just comment on that? D-dimer. A few months back, I had, in a conference, I came across this D-dimer will be useful. Recently also I read somewhere that D-dimer will be useful in a certain situations to distinguish between dissection and coronary artery involvement.
See, in coronary, usually we don't get a D-dimer elevation to a significant extent. Coronary says D-dimer elevation is not very to the significant extent. So if the D-dimer is elevated, you have to think on other conditions, especially pulmonary embolism or other thrombotic conditions or dissection. There can be clot formation in dissection, especially.
Yes, sir. So when you have a ascending aortic dissection and when it extends into the coronary artery, thrombolizing is disastrous. But many times aspirin clopidogrel may not really worsen the scenario. And sir, as you mentioned, when thrombus formation occurs, definitely D-dimer has to be elevated, but it never happens in an acute coronary syndrome.
Thank you, sir, for highlighting all the points. Especially history is very important. Each part is important. It has to be an integrated evaluation in a chest pain. Otherwise, we will miss. History may be only the clue. Everything may be normal. Examination may be a very important thing. Especially, I had seen pericarditis with ST elevation being taken for primary angioplasty without auscultation, but there was extensive pericardial rub. ECG may be non-diagnostic. ECG may be normal. Many situations where with one ECG patient was sent and dying on the way. Echo can be misleading. Whenever we see ECG changes, we will tend to think there is RWMA, or echo can be even normal. Even angiogram can be normal because we have MINOCA, that is myocardial infarction with the normal coronary artery. So it has to be integrated evaluation starting right from the chest pain up to the angiogram. Yes, sir. There are 4 types of early repolarization here as type 1, 2, 3, 4. The type 1 is the innocuous one seen in young people with mid-precordial leads only showing a V2, V3, V4. Usually seen along with bradycardia, innocuous. Whereas the type 2, 3 and 4 we have to be cautious. Type 2 means it is in the infralateral leads, ST elevation is there. That has a slight tendency for VT and VF and sudden death. And type 3 is the one which is more dangerous. We have type 3 and 4. Type 3 is global ST elevation. There is ERS in all the leads, including sometimes right-sided leads. That is the most dangerous, higher chance of SCD. And type 4 is our Brugada. So type 3 and type 4 has to be cautious.
Sharma sir, I think one point I would like to say is that if the D dimer, if you are suspecting a case of aortic dissection, if the D dimer is negative, then you can safely rule out dissection. So it has got a negative predictive value rather than a positive value. Thank you, Deepak sir.
Thank you.
Any other question or anything? Because
Thank you so much, sir.
thank you. I think let us give a big clap to Deepak for having an extensive coverage.
Inviting Dr. V.L. Jayaprakash to present a memento to Dr. Deepak Davidson. I'd like to welcome Dr. Shobhana Devi, HOD of Gastroenterology, to present a memento to Dr. V.L. Jayaprakash and Dr. Praveen Jain. We'll be proceeding with our inauguration ceremonies. I'd like to invite onto the dais Dr. R.N. Sharma, Dr. V.L. Jayaprakash, Dr. P. Sugumaran, Dr. Sojan Skaria, Dr. Sadakatullah, and Dr. Shaji K. Thomas.
Good morning to all. Since our chief guest is down there, sir will be joining in 5 minutes' time, so that I thought I will proceed with the inauguration ceremony, and sir will join in 5 minutes' time. Okay. It's a great pleasure and privilege to be here in front of my own teachers who had taught me the fundamentals of medicines in Kottayam Medical College. We got plenty of crowds are there, senior doctors are there, friends and colleagues. Today, this is the 5th CME conducted in the name of KIMS academics. This time I have selected a very simple topic, very useful topic useful in everyday practice for the general practitioners. We got a distinguished guests, so many are there here. Before going to the this time this is something special for the program is there. These subjects are dealt with one of the highest quality speakers. They are all very renowned in nationally and internationally, and also the chairpersons for the programs. They are of the highest quality in the society and very well experienced in the subject of medicine. And this is the first time the program is being shown through YouTube live. And almost 10,000 links were shared across India. And all the programs will be permanently there in the YouTube. So those who have missed the programs also, they can watch the program on YouTube again and again. First, sir will be coming. So anyway, let me welcome Thiruvenjur sir. Sir also doesn't require any introduction because most of the doctors here, they have a very good close contact with Thiruvenjur sir. Personally, most of the doctors knows him very well. Sir had been in the field for almost 33 years, many times as minister, as an MLA of Kottayam for the past 12-13 years. And I got a very close association with Thiruvenjur sir. The only specialty I've seen is whenever I used to go at his house, even in the night also, his gate never get closed. It is open 24/7 for the public. Whenever in any problems, irrespective of your caste, creed, or whether you are rich or poor, anybody, sir is there to help the people. That is the specialty of Thiruvenjur sir. In his absence, I am welcoming him to the KIMS Academics program. Now you got some of the eminent teachers. The long list of teachers are there for the programs. First, let me welcome senior most professor of Kottayam, Dr. R.N. Sharma sir. Sir is the head of the Department of Medicine, Pushpagiri Medical College. Whenever sir's names comes, sir is like a great teacher. That was a designation for him was given by, and a great clinician. Sir was been awarded a Best Teacher Award by the API Kerala chapter. When in doubt, for many of the doctors sitting over here, the first goal goes to Sharma sir, and sir solved the problem in a nick of time. That is why sir is known as a walking encyclopedia in medicine. Welcome, sir. Then next, the senior most professor of pulmonology, Sir Sumaran sir is here. Sir is a master in pulmonology. I was his student in Kottayam Medical College. The specialty is something different. Sir always have a love and affection, encourage, very closely associate with the undergraduate, postgraduate, even his own colleagues. And when I approached for a talk, Sir said, give the chance to others, let them grow. That is the attitude. That is something specially about Sukumaran Sir. Welcome, Sir. Then we got the senior most professor of cardiology, emeritus professor of Kottayam Medical College, Dr. V.L. Jayaprakash sir is there. Sir is very highly academic, a great orator, a great academician. More than that, he is a great violinist. Under his leadership, Kottayam Medical College Cardiology Department has grown to such an extent that it became the #1 center in the country to do the primary angioplasty. Welcome, sir. The senior physician, sir, 2 minutes. Okay. So, one of the senior physician of Kottayam, Dr. Sojan is here. He's a current president of Physicians Club of Kottayam. Great academic person. He is in charge of diabetic education in Kottayam for the past 5 years. Welcome, Dr. Sojan. We got a big faculties starting with Dr. Deepak also, so we have done a wonderful job just now. He's a man of technology. His interest is a complex cardiac catheterization center. He was the first person to do a successful laser angioplasty in Kerala. Congrats, Dr. Deepak. Dr. R.V. Jayakumar sir will be joining soon. When I joined the MBBS in Kottayam, sir was the only endocrinologist we can see in Kottayam. And that department was not grown to that level. But even after almost 30 years, still most sorted endocrinologist in Kerala is Dr. Jayakumar. So in his absence, I am welcoming him also. Dr. P.K. Jabbar will be joining soon. He is currently the head of the endocrinology department in Trivandrum Medical College. He is a director of Diabetic Institute in Trivandrum. He is a DM examiner, as a great speaker, national as well as international speaker. And I also welcome Dr. P.K. Jabbar. Dr. Unni sir was here. He had given an excellent talk on thrombocytopenia. His area of interest is hematology. Even though he's a medical oncologist, his area of interest is hematology as well as the leukemia. Welcome, sir. Dr. Vijaykumar sir was here. Sir's son is our medical superintendent. Sir was a commonly seen in all the academic platform. Welcome, sir, also. Dr. Jeevan Joseph, who is running his own endocrine center, is only one endocrine center in Kottayam. He's a highly academic person, has done his degree from UK on endocrinology, and is a powerful coordinator also. Welcome, Dr. Jeevan. Dr. Harikrishnan sir is here. So far, we don't have, in our time also, we never had a rheumatologist in Kottayam Medical College. After long time, Kottayam Medical College is lucky to have a rheumatologist, Dr. Jaykrishnan sir Harikrishnan sir is here. So welcome, Dr. Harikrishnan. Dr. Venugopal is there, very close friend of mine. Is a very simple and humble professor of pulmonology in Kottayam, and he's a very genius person, and he will be giving a talk on extra chest soon. Welcome, Dr. Venu. Dr. Raju sir is here. He is head of the fertility unit in Metera Hospital. When in Kottayam, people talk about IVF, the first name come to the mind is Dr. Raju. Welcome, sir. Okay. Sir was not here for some time. Okay. So, anyway, Thiruvanjuru sir and we got a very close relation to sir and sir, his family. And I used to visit his family regularly, and sir also comes to mine also. When in any problem in Kottayam, the only name the public used to say, we will go to Thiruvanjuru sir and we'll solve the problem. Sir is always there to help, and as I mentioned earlier, it is 24/7, door is open to the public, as well as anybody comes, sir will do whatever possible from his side. Welcome, sir. We got a long list of physicians are here. Dr. Rajib, the secretary of Physicians Club Kottayam, is an academic person. Is also from Bharat Hospital. And Dr. Rajesh Menon is also from Bharat Hospital, senior physician from Bharat Hospital is here. And from Medical Center, we got Kurian Saver is there. And from Kottayam, KIMS Hospital, Dr. Anil Matthew will be joining soon. So welcoming all together since lack of time. Okay. So I miss anybody? Okay. So I also welcoming, I hope all of them were discussed. Okay. Also welcoming the media people who has come in, both from the Manorama, ACV, and all, welcoming those people. And in a big number, the doctors has come from the far off place on this Sunday, sparing their valuable time. Welcome all of them together. And our past medical superintendent is here, Dr. Shajike Thomas, who was there for helping. And at this moment, just express my sincere thanks to those like M.S. Sahadullah, the chairman, the Prakash sir, our administrator, and so many people from KIMS Hospital is there, Dr. Asif is there, Dr. Grish is there, so many people are there. I am not want to mention each name, and welcoming all the people to the program. Welcome, sir.
I'd like to welcome Dr. R.N. Sharma to felicitate Honorable MLA of Kottayam, Sri Thiruvanjuru Radhakrishnan sir. I'd like to welcome sir for the lamp lighting ceremony. I'd like to welcome Honorable MLA Sri Thiruvanjur Radhakrishnan sir for the inaugural address.
ബഹുമാന്യരായ വിശിഷ്ടാതിഥികളെ, നമ്മളുടെ ആരോഗ്യരംഗത്തെ പ്രബലരായിട്ടുള്ള എക്സ്പേർട്സ് അടങ്ങുന്ന സഹോദരങ്ങളെ, എനിക്ക് കൃത്യമായിട്ടറിയാവുന്ന ഒരു ചടങ്ങ് ഞാൻ ആദ്യം നിർവഹിച്ചു. നിലവിളക്ക് കൊളുത്തുക. ഒരു പ്രൊഫഷണൽ കോൺഫറൻസിൽ എനിക്കുള്ള സംഭാവനകൾ വളരെ ചുരുക്കമായിരിക്കും. അത് പ്രൊഫഷണൽ എക്സ്പേർട്സിന് മാത്രമേ ഈ രംഗത്ത് കൂടുതൽ വിവരങ്ങൾ പറയാൻ കഴിയും. പക്ഷേ ഇതിൻ്റെ സംഘാടകരായ സഹോദരങ്ങളെ ഞാൻ അഭിനന്ദിക്കുകയാണ്. കാരണം നമുക്ക് നമ്മുടേതുപോലുള്ളൊരു പട്ടണത്തിൽ ഈ എക്സ്പേർട്സിൻ്റെ ഒരു ഇൻട്രാക്ഷന് സൗകര്യം കിട്ടുക എന്ന് പറയുന്ന വലിയ കാര്യമാണ്. അതിനുവേണ്ടി ഒരു വേദി ഒരുക്കി എന്നുള്ളത് ഞാൻ പ്രധാനപ്പെട്ട കാര്യമായി കാണുകയാണ്. ഡോക്ടർ പ്രൊഫഷനിൽ ഞാൻ പുറത്തുനിന്ന് കാണുമ്പോൾ ഏറ്റവും പ്രധാനപ്പെട്ട കാര്യം കൺസൾട്ടേഷൻസ് തന്നെയാണ്. നിങ്ങൾക്ക് പരസ്പരം ആശയവിനിമയം നടത്താൻ, നിങ്ങളുടെ അറിവുകൾ ഷെയർ ചെയ്യാൻ, അങ്ങനെ പുതിയ ഉയരങ്ങളിലേക്ക് പോകാൻ കഴിയത്തക്ക വിധത്തിലുള്ള ഒരു പ്രൊഫഷണൽ ടച്ച് ഉണ്ടാക്കാൻ കഴിയണം. സാധാരണഗതിയിൽ കോസ്മോപൊളിറ്റൻ പട്ടണങ്ങളിലൊക്കെ പ്രൊഫഷണൽ ജയൻസ് ഒരുമിച്ച് ചേർന്ന് അവരുടെ പ്രവർത്തനങ്ങളെക്കുറിച്ചൊക്കെ ആലോചിക്കാറുണ്ട്. ആരോഗ്യരംഗത്ത് എനിക്ക് തോന്നിയിട്ടുള്ള കുറേ കാര്യങ്ങൾ ഈ ഒരു പ്രൊഫഷണൽ കോൺഫറൻസിൽ പറയാൻ പറ്റുന്നതല്ല. അതൊക്കെ ഇതിൻ്റെ പുറത്തുള്ള ആളുകൾ, ഞങ്ങൾ സോഷ്യൽ സയൻറ്റിസ്റ്റുകളെന്ന് പറയുന്നത് പോലെ സാമൂഹ്യ രംഗത്ത് നിൽക്കുന്ന ആളുകളാണ്. പരിധി വിട്ട് പറയുന്നത് ശരിയല്ല എന്നെനിക്കറിയാൻ ചെയ്യാം. അതുകൊണ്ട് നമ്മുടെ പ്രൊഫഷണലിസം മാക്സിമം ശക്തിപ്പെടുത്തുന്നതിന് വേണ്ടിയുള്ള നല്ല ധാരണയോടുകൂടി പോകാൻ ഈ കോൺഫറൻസിന് കഴിയട്ടെ എന്ന് ഞാൻ പ്രാർത്ഥിക്കുകയാണ്. യഥാർത്ഥത്തിൽ നമ്മുടെ ആരോഗ്യരംഗത്ത് പുതിയ ഒത്തിരി സ്ഥാപനങ്ങൾ വരുന്നുണ്ട്. കേരളം അതിന് പുറകിലൊന്നുമല്ല. പക്ഷെ നമ്മളേക്കാൾ മുമ്പിൽ മറ്റു പല സംസ്ഥാനങ്ങളുമുണ്ട്. ഏറ്റവും പ്രമുഖമായ ആശുപത്രികൾ നമ്മുടെ നാട്ടിൽ ഇനിയും വരേണ്ടിയിരിക്കുന്നു എന്നുള്ള വിശ്വാസക്കാരനാണ് ഞാൻ. അതിനുപോൽബലകമായി എൻ്റെ മനസ്സിൽ തോന്നുന്ന പൊതുവികാരങ്ങളുണ്ട്. ഞാനത് ഇതുപോലൊരു ചർച്ചയ്ക്കകത്ത് കൊണ്ടുവരാൻ ആഗ്രഹിക്കുന്നില്ല. നിങ്ങളെ ആശ്രയിച്ചും നിങ്ങളുടെ പ്രവർത്തനത്തിൻ്റെ വിജയത്തിൽ കേന്ദ്രീകരിച്ചുമാണ് നമ്മുടെ സമൂഹം സത്യത്തിൽ മുന്നോട്ട് പോകുന്നത്. അവർക്ക് നല്ല പരിചരണം കൊടുക്കുന്നതിന് നിങ്ങൾക്ക് കഴിയും എന്നെനിക്കറിയാം. ഈ ചർച്ചയിൽ പ്രധാനപ്പെട്ട 5 സബ്ജക്റ്റുകളെക്കുറിച്ചാണ് ചർച്ച നടത്തുന്നത് എന്നാണ് ഈ ഇറക്കിയിട്ടുള്ള ബുള്ളറ്റിൻ കൊണ്ട് എനിക്ക് മനസ്സിലാവുന്നത്. അത് നന്നായി മുന്നോട്ട് പോകട്ടെ. നമ്മുടേതായ ഒരു സംഭാവന കേരളത്തിൻ്റെ ആരോഗ്യരംഗത്തുണ്ടാവട്ടെ. ഇതുവരെ ചെന്ന് പ്രവേശിക്കാൻ കഴിയാത്ത മേഖലകളിൽ നമുക്ക് എത്തിപ്പിടിക്കാൻ കഴിയട്ടെ എന്നൊരു കൂടി പ്രാർത്ഥിച്ചുകൊണ്ട് ഞാൻ നിങ്ങൾക്കെല്ലാവർക്കും ഭാവുകം നേർന്നുകൊണ്ട് എൻ്റെ വാക്ക് ചുരുക്കും.
We invite Dr. Sadakatullah to give a memento to our chief guest, Sri Thiruvanjur Radhakrishnan MLA.
Thank you, dignitaries. We'll be moving on to the next session. Interpretation of chest X-ray. I'll invite onto the stage speaker Dr. Venugopal, Professor of Pulmonary Medicine in Kottayam Medical College, and Chairperson Dr. P. Sugumaran, HOD of Kottayam Medical College, and Dr. Sojan Skaria, Senior Consultant in Caritas.
Dear friends, after the extensive advanced talk on ECG, we are going to have a talk on interpretation of chest X-rays. We know William Röntgen discovered X-ray and made it in the diagnostic field in 1895. It's almost 120 years, and even though it was the first clinical application in medical field, it still remains very efficient, and it is one of the most important investigation routinely done by us in any disease. Not to rule out chest X-ray, and chest X-ray is the initial assessing tool in any clinical investigation of any disease in pulmonology, and it is very useful, and we all know it's very useful. And not only that, even though we have got recent advances in CT, MRI, PET scan, and combinations of these, but still X-ray should be, chest X-ray, simple chest X-ray should be one of the first investigations we do, because you need not go to a specialized center, and X-ray is available every year, and it's very cheap, and patient can easily get the use of chest X-ray, and it gives the initial assessment. A very, very simple and important topic, but very difficult to cover in 20 minutes. I'm very sure that's what Venu must be thinking. And to introduce the speaker, I hand over the mic to Dr. Sojan.
Thank you, sir. I am privileged to introduce, even though this audience doesn't need any introduction, of Professor Venugopal, sir. He is currently the HOD of Department of Pulmonology at Kottayam Medical College. He did his MBBS and MD at Kottayam Medical College. He is a very, Professor Sumaran sir is very proud of his student. Even his academic performance and his performance at the time of his examination, he just now mentioned to me, we are proud of you. Not only that, he is also an artist in his heart. He has received a State Sahitya Academy Award for Unnikuttante Doctor. Yeah, he is in that way also highly acclaimed. I doesn't want to waste any time. Your podium is yours.
Good morning to all, my dear Sumaran sir, teachers, other teachers and colleagues. And at the onset, I would like to thank Sadakat, he is my friend, and his KIMS team for giving me the opportunity to talk before you. And good for that good words, thank you, Sojan. And Sumaran sir is my mentor, and he's a teacher. Except for him, I would not have been in this field. I would have been just a pediatrician. And just to start with, so as sir said, X-ray is an important tool, a diagnostic tool for all, especially for pulmonologists and medicine physicians. Even after more than 100 years of this discovery, we have got more and more tools now, diagnostic tools now, but still the importance of X-ray is still there, especially in a basic areas where we are not working on having CT or other imaging. X-ray is still important. And what's an X-ray? It's just a two-dimensional black and white picture of a three-dimensional body. So it has got its own limitations. And what we can see is only two colors, black of air and white of a fluid, anything. So whenever something is more white, it is either a metal or a bone event, and you can see something in between black and white, that's the color of fat. So how can you identify something from an X-ray is mainly because of your knowledge of anatomy of the lung and your knowledge of pathological changes that occur in various clinical conditions. So with that, nowadays we are not using the old conventional chest X-rays. Now you have got the digital radiography, and here there is no problem with the exposure defects and all, because the images can be adjusted even after the exposure, and so the need for retakes are very minimal. The technician can adjust the exposure and all, and a computer manipulation of the digital image is possible, and you are able to focus on various soft tissues and bony tissues as you wish. And for the chest X-ray, we have got these various projections, the PA view, AP view, or lateral, which we commonly use. And in special situation, we can ask for oblique views or lordotic views. And we all know a chest X-ray, often when it is not prescribed, the X-ray we get is a PA view. And PA view is more important as far as a medical person is concerned, because it gives the normal size of the heart and it focuses on the anterior part of the chest. And for a AP view, you will be giving more stress on the posterior aspects and the spine. So when you are getting an AP view for evaluation, you always see that the heart size cannot be judged on that. And the supine film, that's very important, especially in the casualty or in an emergency. The patient cannot stand up for a PA view. We always get a supine film. And the supine film has got its own limitations, especially the diaphragm will be coming up and you are not able to see whatever in the lower side of the chest, and the heart size cannot be measured. And also the most important problem we have seen, and actually this a person, especially a patient comes after a polytrauma, and you suspect a pleural effusion. Maybe it's a hemorrhage into the pleural cavity. And what you can see is just a haziness of in the chest X-ray. It is not the whiteness of pleural effusion there. So when you suspect a pleural effusion, or in another case, if you have a patient, especially the polytrauma, and you are taking a supine film, especially in the ICU, you are taking a supine film, you may get an apparent translucency on one side, and you suspect you should have a clinical suspicion of pneumothorax. And in such cases, whenever there is an ultrasound, that is the first choice. You can identify, you can rule out, or you can discover the pneumothorax or effusion in the ultrasound. But if you do not have one, the best thing you can ask is to go for a lateral decubitus. And actually this has happened on pediatrics assistant professor in Trivandrum. He had a small traffic accident and he came to the casualty. There was a haziness, but they all thought that it was not very important. And he went back, and after some day he came in distress and he died. And it was just a hemothorax they missed in the first X-ray. And it is very important. So in the casualty or in the ICU, wherever you are seeing a supine X-rays, you do not go by that. It is always your clinical examination that's important. Go for an ultrasound. If not there, you always go for a lateral decubitus, which is very well available. So if for a smaller effusion, you can always ask to take the lateral decubitus on the same side so that you can see these lamellar effusions there. So for a suspected pneumothorax, you have to ask the X-ray on the opposite side. Lateral decubitus has to be asked on the opposite side, because you can see the deep sulcus. A small air can be seen as a deep sulcus sign on this lateral decubitus. So that is very important. And this also has happened even in medical college. A person with a head injury, we missed a pneumothorax, and later the patient died, and there was a lot of problems after that. So this has happened. So this has to be taken. Whenever you read a supine film, you always go by the clinical examination rather than the X-ray. So always ask for, whenever you are in doubt, you suspect something on one side, you always ask for a lateral view of the same side for completion's sake. So now, before you start reading, it's always important to have an ambient atmosphere for reading the X-ray. So you have to turn off all the stray lights. The optimum rotating should be there, and the view images in order if the previous images are available. And always try to use a view box to read the X-ray rather than keeping it in your hand against a light. So it's important to identify the identity, because especially in a place like medical college where there are so many patients, or the patient may have a bench of x-rays with him, maybe his husband's or wife. So always identify. For any examination, any document the patient hand over to you, the first thing you have to confirm is the identity of the patient. That's very important. And why? Because you may be reading upon somebody else's x-ray and maybe giving a clinical diagnosis. So it's very important. Always confirm the identity, then confirm the date and time. If there are different x-rays taken on the same day, you have to see the date and time also. Because we use the x-rays to see whether the disease is progressing or the condition is improving. So for that you have to have a dated x-rays, and you have to see the x-rays in order. And suppose this patient came with an x-ray, you have a shadow on the right lower zone, and probably it's a mass lesion. But if you have the patient has an x-ray which is taken 6 years back, showing the same shadow, so you avoid further unnecessary tests, because it is what you see is a shadow. That's a shadow which is previously there, most likely a hamartoma. So it's always important to have previous x-rays. And right or left, always it's very easy. You always go to see the right left heart border and see it is a left. But you will be always right, but sometimes a patient with dystrocardia come, it will be in trouble. And then before going to read the x-ray, you have to assess the quality. It should be a complete x-ray, so that you should not miss something in the subcutaneous tissue or the neck or in the abdomen. And with the exposure, it is not a problem nowadays with the digital film. They will be already corrected by the technician. But an overexposed film is almost that will look more white, and underexposed film looks more white, and overexposed film look more black. And we may miss things in an overexposed film. And sometimes it is subtle soft tissue shadows or interstitial shadows may not be available, may not be seen in a patient who has got an overexposed x-ray. To see how the normal exposure, you could be able to just see the spines or the vertebra behind the heart. If it is more seen, it is overexposed, or it is more black, it is overexposed. The chance of missing subtle things and interstitial diseases are more likely. So the position is important. In a rotated view, it is very difficult to assess the hilum, and apparent translucency on one side also will be there. So the moving side is the clavicle. When you are not in a normal position, you may rotate to one side or other. Always compare the distance between the medial end of the clavicle from the spine. It should be equidistant. And the other thing, usually we always need to have an inspiratory film. That means you should be able to count 6 or 7 vertebrae anteriorly, or 10 or 11 posterior ribs. So if it is an expiratory film, the heart size may appear big, and you may not be able to see something which is in the lower zone. So always ask for an inspiratory film. You may need an expiratory film when you suspect a small pneumothorax, or when you need to know whether there is air trapping or not. Otherwise, an inspiratory film is a must. So always look for artifacts, maybe from the chest wall as iatrogenic or something outside in the chest wall. So you have to always look for the artifacts. So all the tubes has to be seen and described. Sometimes we may take an chest X-ray just to see where your this intratracheal tube is or the nasogastric tube is. So they look for the tubes always. Now, I'm not going in detail about the chest X-ray anatomy. That is well known, and that is a basic thing with which we can identify a chest X-ray. So, and which are all the subtle things in the chest X-ray, which are the borders, or all those small things you have to learn by heart before going to read an X-ray. And when you start reading the X-ray, you have to be systematic, and that means. Usually many follow the ABCD, start from the airways, but we prefer to see before that the skin, soft tissue and the bones, because they are the areas which we may not look once you straight away look into what is to see the elephant in the X-ray or whatever is prominent in the X-ray. You may not go for the detailed anatomy and you may miss things outside. So skin, soft tissue, bony cage, then go to the trachea, then hilum, cardiac, and then diaphragm, pleura, then come back to the lung. And the lung is divided into 3 zones. You cannot describe lung lobes there in a chest X-ray because it is only 2 dimension. You can just say it is upper zone, mid zone, or lower zone by 2 imaginary lines drawn at the second rib or the fourth rib. So it's very important, and you have to describe things in specific patterns in this. So it's an importance of looking systematically at the X-ray. And what you see here is otherwise it is a normal, apparently normal X-ray. What you see here is just some air shadow in the neck, and this is due to a tracheal fracture which has lead to a subcutaneous emphysema. So looking at this otherwise unnoticed area is always important. If you look sharply at the trachea, you may identify a tracheal stenosis sometimes. And other area which is very important is the paratracheal stripe, which is otherwise a thin line between the lung and the tracheal layer. If it is widened and it is a lobulated widening, suppose you may be identifying a lymphoma very early. So this is very important to go systematically. And then sometimes, unless you look beneath the diaphragm, you may miss gas under the diaphragm as you miss it. So other area you may miss in a chest X-ray is the behind the heart, because this is very seldom you may see this area. So you can see a fluid level behind this heart, and there is a gas there. So this is achalasia cardia, and sometimes a small mass behind the heart may be missed, or sometimes a hiatal hernia may be missed. So always look behind the heart also. So these are the hidden areas. You look for the apical zones. That's behind the clavicles, you may miss something. Then the hilar zones, the retrocardiac zone, and the zones below the dome of the diaphragm especially, you have to look specifically. And then about something about the heart, you have to assess whether the heart size is normal or not. But for this, you have to have a proper PA view, and you should have a inspiratory view. And it should not be rotated also. Then it is the ratio between the transverse thoracic diameter and transverse cardiac diameter, which we should always try to see the heart right and left should be assessed on from the midline separately. And after all this assessing the quality and looking at the type of X-rays, our duty is just to identify the lesion, where exactly is the lesion, try to localize the lesion, and then describe the pattern, and then give a differential diagnosis. Many of the time we may not have a definite diagnosis. We can only go for differential diagnosis, and with which we can go for the further investigations which we require. And the X-ray pathologies, what we have is either some lesion is too white, or black area is something, it is a too white area, or it is more black, or something which is normally seen is more larger in size, or something is seen in the wrong place. So these are the usual things we have. So just see what happened when there is a too white thing. We call it as an opacity, and then we can just say from the pattern what is this whiteness. It can be a consolidation, it can be a nodule or a mass lesion, it can be a collapse segment, or it can be just an interstitial shadows. And just before that, we'll just try to localize the lesion. Most important thing to localize the lesion with a chest X-ray, you always ask for a lateral view. This is a lateral view. It gives immense knowledge from a lateral view about this thing. You can identify the lobes. So we are using these fissures, horizontal fissure as well as the oblique fissure. You can identify whether it is a lower lobe or the upper lobe. And the lateral view gives a clear idea of the lower lobe. Lower lobe is not very clearly seen in a PA view. So always to see something in the lower lobe, you have to go for a lateral view. And for the mediastinum also, you have to have a lateral view, whether it is anterior mediastinum, middle, or the posterior mediastinum. Then to identify both diaphragms also, you need a lateral view. So lateral view is very important tool for localizing the lesion. And then we have got certain signs to localize the lesion. That most important is a silhouette sign. To have the silhouette sign, you should know the normal anatomy of the mediastinum diaphragm, and you should know which all structures are in close opposition to these known structures. For example, you have got a shadow here. There is a white shadow here, and you are not able to see the right hard water clearly. So something has opposite, or something has silhouetted the right heart border. So that should be right middle lobe. So right middle lobe comes in relation to the right heart border. So another example is you have got a shadow here in the left mid and lower zones, and you are not able to see the left heart border, but you are able to see the left diaphragm very clearly. So those things which is obliterating the left heart border and not obliterating the left diaphragm is the lingula. So it is a lingular lesion. So another sign which you can use to localize is a cervicothoracic sign, especially when there is a shadow in the right upper zone. So if you have got a shadow in the right upper zone and your mediastinal shadow, it can be, if it cuts shorts at the clavicle, it is likely to be an anterior one. But if you can see the upper border above the clavicle, it should be in the posterior mediastinum. And then it's a something in the pleura or not. This is a pleural shadow. A pleural shadow always will have the broader base towards the pleura, and there should be it makes an obtuse angle with the pleura, and then this is a classical extrapleural sign, and you can see that it is a pleural lesion. And suppose if it is a lesion in the lung itself, lung parenchyma, which is going and touching the pleura, then the broader base may not be towards the pleura, and it makes an acute angle. You can see it makes an acute angle with the pleura. So this is a mass lesion. The other thing is a extrapleural sign. So for the hilar shadows, it can be a hilar lesion or it can be a vascular prominence. So usually if it's a hilar lesion, you can get the hilar overlay signs. That means you can see the vessels over this mass lesion. So then it should be a mass lesion. So it's a hilar convergence sign. Usually you will see the vessels converging into this shadow. So this also you can identify to localize whether it's a hilar lesion or a hilar vascular lesion. Then coming to the patterns, the most common one or most sought after, most commonly we take an X-ray to identify whether there is a pneumonia or not whenever there is an infection. So you look for consolidation. So for consolidation, ideally it is a replacement of air. That means it should have a lobar or segmental distribution, and there won't be any volume loss. And the classical sign of a consolidation should be an air bronchogram. So there is a white shadow which is goes according to the lobar or segmental distribution without causing a volume loss, and air bronchogram sign will be the consolidation. So this is an example. This is a classical example of a right upper lobe consolidation. You have got the opacity there. The trachea is not shifted. You can see the horizontal fissure on the normal position, and you can see the air shadows inside this opacity. So it's a classical right upper lobe consolidation. And you can take a chest X-ray lateral view to confirm. And the consolidation, here is the consolidation of the right middle lobe. You can see the right heart border is obliterated. There is air inside the shadow. So this will be a right middle lobe consolidation. So, and the lingula, you can I have already said. And coming to the lower lobe, especially the lower lobe consolidation may be even missed if it goes behind the diaphragm. So you always need to have a lateral view to assess that, especially for a lower lobe consolidation. Here you can see the heart border, sharp heart border. So it is unlikely to be in the lingula. It is unlikely to be an anterior one. And the lateral views you can see. Usually, below the hilum, the shadow, the areas will be very clear in lateral view. Any opacity there you should always suspect a lower lobe lesion. And if it is an extensive wideness, that's the consolidation, bilateral consolidation with air bronchogram. This classically seen in ARDS or similar pictures. So this is a common one we always see whenever there is a bilateral upper zone fluffy shadows or patchy consolidations. This is classical of pulmonary tuberculosis. And then the next important thing is a collapse atelectasis. So this is an upper lobe collapse. You can see this patient is having an upper zone shadow and the trachea is shifted, and also the the horizontal fissure is also moved upwards. So that means there is a volume loss associated with the wideness, and there is no air bronchogram sign. And you can see the cause of this collapse also here. That is this hilar shadow there. This is classically called the golden S sign. It is not golden for the patient. The upper part of the S is by the this horizontal fissure, and the lower part of the S will be the hilar shadow. And similarly, the right middle of collapse, as you can see, the hard border, this right hard border is not very clearly seen, and in the lateral view, you can see this shadow. So that's a right middle lobe collapse. Then the left upper lobe collapse, there is an interesting sign there. You can see there is a shift of the heart towards the same side, and you can see very clearly. You don't expect the aortic knuckle to be seen in that X-ray. If it is seen, that's a Lucius sign, which is due to the hyperinflation of the lower lobe. So this also shows that there is a right upper lobe collapse. And this is another X-ray for the right lower lobe collapse, which we can see as a double line. One line goes behind the heart. So this is a double line, which otherwise we may miss it unless you look through the X-ray. Look behind the heart, this is a single line, and usually this line may obliterate or silhouette the diaphragm also. So these are this is an X-ray of segmental atelectasis, which we usually see in a patient in the post-surgical cases. We may see segmental atelectasis, and we just rush through the other things. It's a mediastinal mass lesion. You have got the broad base towards the mediastinum and makes an acute angle with the mediastinal structures. And the hilar shadows, you can have multiple nodes there, and this is the interstitial fibrosis. Here there is one sign. Usually we have to see the heart borders or the diaphragm very clear, and here there is a shaggy interface or this interface sign with the low volumes of the lung. This patient is having interstitial IPF. So these are reticular shadows going up. Then about whole wide lung will be pleural effusion, and one shadow I will say this is important to notice. One shadow, one opacity between the whiteness or the air. And you can just compare this shadow with the subcutaneous fat. So this X-ray itself, we can see that it is not a consolidation or an effusion. This is just fat shadow. It's a pericardial fat. So you can compare this shadow with the subcutaneous fat there. Then about the hypertranslucencies, this pneumothorax where you get the air shadow inside, and you can see the rest of the lung is collapsed towards the hilum. And then other translucency you may see is the bulla. And sometimes this is very important, especially a child coming with a chronic cough. You see a translucency on one side. This can be due to a foreign body with a partial obstruction. And there are cavities which we can easily understand, or bronchiectasis. And probably the time is getting over. I will just stop with this X-ray. And this very easy, so X-rays are still important. This is a patient who came recently to the casualty, and this patient had breathlessness. In addition, the patient had cough, vomiting, abdominal pain, as well as patient had breathlessness. So this chest X-ray was taken in the casualty, and just this is left for a discussion whether what we should do next. So with this chest X-ray, in the casualty, everyone is tempted to identify this as a hydropneumothorax, with the patient coming with breathlessness. A junior doctor may be tempted to even put in an ICD. But when you look clearly, you can see the diaphragm has been, this is a veneration of the diaphragm. You can see the diaphragm going up. So this is a catch. Ideally, you should go for an ultrasound, or ideally you should go for the patient had already history of vomiting and abdominal symptoms also. You should put in a feeding tube, and then you could take another chest X-ray. Then the thing would have been corrected. So sometimes it is possible that we may go wrong. especially in a supine view in the casualty when we are very busy. So then going by a systemic approach and don't jump into conclusions, because X-ray just gives you a clue. It is not a 100% diagnostic thing. If you suspect something, you always go for additional information. For this, an ultrasound should have been better. Or if it is there is no ultrasound, you could just put in a feeding tube and you could take a lateral view. An ICD should have been avoided. So with that, because I know in chest X-ray whole portions cannot be, whole areas cannot be covered within a small topic. So that's I just went for areas which we may miss. And the most important thing is to have it cut, to ask for the proper projection X-ray. If you need a lateral view, you have to ask for that. Lateral decubitus, everything is important. And always go for a systematic review of the chest X-ray. And always look at the hidden areas. You should not miss some things from the hidden areas. That's all. Thank you.
Thank you, for the extensive talk and description of the chest X-rays. And it is always important, if you take an X-ray, you should go systematically, and you should not see. The most important point he stressed is you should not go and jump into the most important thing, and the most important finding. You should go on a systematic way. And though we all know X-ray is available everywhere, it is very cheap, and it is very old, and it has been the most extensively used for initial diagnosis of many medical diseases, especially in pulmonary medicine. And X-ray gives the conclusion, and X-ray gives the initial diagnosis and how to go on with the management. So the most important, the first initial clue you get is from a chest X-ray, whether it is a PA view or AP view. AP view will be useful, it will be not very good to see, but it will give some clues also. And one of the most important things is stressed is pleural effusion when it is there. When you after an accident, which the junior doctors might not have been seen. Myself and Sharma sir must have seen in the casualty, because we did not have any ultrasound was almost a black spot for us. It was not at all good for whenever there is air, you should not use ultrasound. That was the thing we have learned. Now the lung artifacts are seen, not the. Usually, when we do an ultrasound, we see what artifacts are there, and then we stress what is important. So, in such cases, it is very important. And though X-ray is very old, old is always. It is not that it is also golden things. So, X-ray should be judiciously used. And one thing I would like to ask Venu is, can you identify, because you are not gone to that. Well, how about the malignancy and benignity? And now, most of us, when we see an X-ray, we go on to do CT scan. Because it is not stressed also. Even in my student days, it was in 1980s, we were always asked to take a lateral view also, so that we can see the hidden area behind the heart. That is why he said the lateral lobe. And then the ribs were also we see only 60% of the lung shadows. Now we have digital X-rays where the techniques can be done to remove the subcutaneous tissue, to remove the bony cage, and then you can see X-rays. I don't know whether it is available here, but you can remove the ribs and then see the underlying lung also. And you need only one exposure, because the computer or digital this thing will resemble, or they can use the technology to show the different views also. So you don't have to go for lateral and all. So that's all. But malignancy, what do you think? Malignancy. Suppose how will you showed one X-ray which showed a small shadow, and then you ask for a previous film, and then you see how do you, because it is important. Okay. Whether you should investigate or not.
Because it itself is a big topic.
Doubling time.
Especially if the patient is having a shadow, and if the patient is having a previous X-ray, you can see whether it is a size has increased. So you look at the doubling time. Doubling means the doubling of the volume. So if the doubling, if the patient has got a previous X-ray taken 1 month back and now it is more than double, it is likely to be inflammatory. So patient has got, as I showed one, the patient had a shadow mass lesion in one X-ray. 6 years back, the patient has the same X-ray. It hasn't doubled or it hasn't increased in size. So that shows the benignity. Most of the malignancies will double within 45 days to 450 days. That's the previous victim. Or so small cell carcinomas divide very fast. Like that. So if there is a increasing in shadow, is always you suspect malignancy. But nowadays we cannot wait for increasing shadow. There is always protocols defined for shadows. If you suspect even a small shadow, 1 millimeter shadow or a ground glass shadow, you have to go for further CT and then you have to go for that. So if you have got a previous X-ray and the shadow is increasing, always suspect malignancy. And the doubling time comes in picture.
So a large shadow in chest X-ray more than 3 centimeters, if you see first time, you will have to definitely go think of it. And then if there are evidence, if there is no calcification, actually there is no calcification, again you will have to think of malignancy. And then you have to, because now we don't wait, but always ask the patient whether you have a previous X-ray. That's the most important one, because previous X-ray gives you a lot of information where we can, and I always ask my patients to keep one X-ray above the age of 40 years to keep it as a base film and then compare. And if you have those films, then it is very easy that we don't go for further investigation CT. Though it is available now, it's not very, very expensive and it's sometimes not useful. Any comments, sir? Any Sharma sir? Or any questions, comments?
Thank you for the nice class. I was feeling that I was going for an examination. You are taking a class. Thank you so much. Just one. The last slide showed a, I think, eventuation or the stomach is inside this one. I remember that once this was taken, it's a common to make a mistake. And the intercostal tube was put. And what came out was kanji water. Kanji came out. So then only we realized that it really happens. That's number one. Number two, told about lateral decubitus, no? Sir. Pneumothorax, one case. Can you just show the slide for once more?
The last X-ray, could be one, acute dilatation of the stomach. 2, a gastric hernia. Herniation can also occur. And when you see, in one of the cases, it was very interesting. We saw a lower zone shadow, which was a large cavity. Next day it becomes smaller, and then third day it becomes again larger. So then you should definitely suspect herniation.
The first one is having when there is a pleural fluid, you will just have a whitish appearance. It's opaque because it spreads out. It spreads out and there will be air over that. So you will never see that whiteness.
LSS curve.
Sir, the next one is having a small pneumothorax. This X-ray has a small pneumothorax. Actually, it is not visible on the left side. Only thing is that they are doubtful in the lower part. It's a small pneumothorax. Then you go for lateral view. There's a deep sulcus. You can see the X-ray is not very that good, but you can see the deep sulcus.
The costophonic angle will be more down, sir, because it goes down. And in supine film also it may be seen sometimes. But now this is all not very significant because we immediately go for CT or ultrasound. Ultrasound has helped us a lot now. Yes. If there are any comments, any questions? Otherwise, thank you, Venu, for the excellent talk. Thank you very much. Thank you, Sadak, for the...
I'd like to invite Dr. P. Sugumaran to present a memento to Dr. Venugopal. I'd like to invite Dr. Nandakumar, Senior Physician from Chengnasheri, to present a memento to Dr. P. Sugumaran, and Dr. Premji, who's also a Senior Physician, to present a memento to Dr. Sojan Skaria. Moving on to our next session, I'd like combination therapy in diabetes. I'd like to invite our speaker, Dr. P.K. Jabbar, Professor and HOD of Endocrinology in Trivandrum Medical College, also Director and CEO of the Indian Institute of Diabetes, and Chairperson, Dr. I'd also like to invite Dr. R.V. Jayakumar, Professor and HOD of Medicine from Kottayam Medical College, and Dr. Kurian Xavier, Consultant Physician in SH Medical Center.
Good morning. At the outset, let me thank Dr. Sadakatullah for inviting me to chair this session. And the speaker is none other than Dr. Jabbar ji. So that is why even when his name was announced, the whole Kottayam town was given the siren of his arrival. Because he is a rare, he is a flying man. So he has landed in Kottayam, that is why the siren came. So he is going to enlighten us, and before he flies out to his next talk somewhere else, I was told that he is very busy. That is why it was preponed and he is given the lesson. Dr. Jabbar is very familiar with the Kottayam physicians, and he is going to enlighten us this combination therapy, because, and I am sure all the pharma companies are very happy with this topic, and the rule is coming, so we all must be very careful before we eat our lunch here, because it must be displayed that it is all fully given by Dr. Sakatullah and nothing to do with the pharma company. Otherwise, we will all lose our registration, because the rule has come. Rule has come yesterday, I think. 2nd August it has come. So we must, so please put a board saying that this is sponsored by Dr. Sakatullah and only now pharma involvement in it, so that we will be all safe. Dr. Jabbar is, as you know, he was a graduate of Trichur Medical College, did his MD in Kottayam, DM from KIMS Hospital, Mumbai, and he is now the leading endocrinologist of the Kerala, and he is the president-elect of All India Endocrine Society of India, which he is going to take charge very soon, in November or so, I think. So with these few words, I invite Dr. Jabbar to give his talk on this combination treatment.
Good morning, everyone. My respected teacher, my mentor, Dr. Kurian, my teacher, Dr. Sharma sir, Sumaran sir, esteemed delegates, friends, ladies and gentlemen. First of all, as the IMC regulation is there, nothing to disclose. Okay, this session is not sponsored, and the topic or caption for the topic is combination treatment for type 2 diabetes mellitus. What I'm just planning to do here is to give a in-depth data, 17 or recent data published in the Lancet Endocrine Metabolism, and which gives lot of discomfort for physicians, administrators, and the patients probably. I will read the data. I'm one of the, at least, see, here you can see my name, Kottayam Jabbar. Okay, it's an error, but it's happened like that. Of course, see, the main concept was designed by Dr. Mohan. Of course, MR sir is also actively involved in the discussions also. And we came out with this in-depth data. In-depth data, please read carefully. See, you have maximum diabetes patients. The national prevalence, please read, the national prevalence is around 11.5. And pre-diabetes is around 15.3%, hypertension. You can read the data here. Please look into the other aspect also here. The state with the highest prevalence. The total prevalence is 11.4 and the highest prevalence of hyperlipidemia, that's for Kerala state. And if you look into the abdominal obesity and generalized obesity, that the rank goes for Puducherry. So highly heterogeneous group. Please remember that. I will discuss the implications also. So this is the diagrammatic representation which gives diabetes prevalence is very high. Kerala, if you concentrate on the right side, the diagram, Kerala is having a figure more than 10, probably above that. I will read the exact data also. Please wait for that. The pre-diabetes also, you can see here, Kerala is having highest number here. Your neighboring states like Tamil Nadu and Karnataka, they don't have that much of pre-diabetic patients. See, they're highly heterogeneous. We do not know, or physicians doesn't know what's happening in the prevalence and contributing factor for increase in prevalence of pre-diabetes and diabetes. So if you see the data, this is the real data from Kerala state. So Kerala state, you have maximum number of patients with the diabetes mellitus. See, 24.7% in urban area, and rural area it's around 23%, and overall prevalence is 23. One of the important point here is there is no difference between urban and rural. See, previously we thought urbanization is making lot of confusion and getting lot of lifestyle related diseases. Now it's not really true. And the pre-diabetes mellitus, it's a slightly lower side, 16 to 18%. Please remember the heterogeneity in the prevalence. This is again incidence of hypertension. So we are discussing about the diabetes scenario, and hypertension scenario, it's also very high. We will look into our own data. Our own data, please see this is around 45%. It's not a simple joke. So 45% of the patient has got hypertension. So multiple risk factors, multiple lifestyle diseases is coming up in a big way. And if you see the obesity part also, again Kerala's color is almost same. Red, always red. And if you see the abdominal obesity part also, Kerala is having lot of cases or individuals that are having abdominal obesity. See, these are real data from Kerala state. Generalized obesity and abdominal obesity to a tune of 62%. Very huge number of patients or individuals after 18, they are having abdominal obesity. Now this is regarding the hypercholesteremia. Here also in Kerala picture is also half of the population above 18 years, they are having this problem. I want to discuss this topic. It's very important topic. This is published by Dr. Vijay Kumar from Pandalam. See, what is written there is not the prevalence, it's the incidence. So it's changing from or developing diabetes or new cases of diabetes mellitus, which is also very high, and they could document 5 risk factors for developing diabetes. What are the risk factors? We'll see here. The one factor is age, non-modifiable one, and family history of diabetes, which is not modifiable, and BMI of obese range and presence of central obesity are the significant risk factors for developing new diabetes mellitus. This data is from, I'm just reminding you, this is from Kerala State, Pathanamthitta district. Now, let us discuss the characters of a classical Kerala patient or Indian patient. Slightly different, there is no doubt about that. There are a lot of differences when you compare the phenotype or profile of an Indian patient versus Western patient. Now, coming to the topic now. So 7% is a magic figure. None of the data, you take any data, you take your own data from your own clinic, most of the patients, at least internationally, around 40% of the patients with diabetes mellitus, they are having good control of diabetes mellitus. Remaining 60% or around 2/3 of the individuals or with the diabetes patient, their diabetes is not under control. So what is the implication of the glycosylated hemoglobin or increasing the prevalence of glycosylated hemoglobin? A lot of complications are linked with the increasing glycosylated hemoglobin. That's only implication. Now, coming to the ground reality, if you see the international data, it's a blue line is uncontrolled. Of course, their part also, in their country also, the glycosylated hemoglobin is not under control. And if you come to the Indian state, see here what is happening in a huge number, very significant number of patients, they are having uncontrolled diabetes mellitus. This is one data, this is from North India, so you can call it as tight data. There also significant number of patients that are having uncontrolled diabetes. This is the data from INTAB data. INTAB data also giving the same message, diabetic patients are not getting good control. Now, this is today trial. It's international, various phases of trial. See, today, first phase, second phase, everywhere, glycosylated hemoglobin was not under control. So far, we have discussed about INTAB data. Number 2, patient has got uncontrolled diabetes mellitus internationally, especially in Kerala state also, simple message you'll get from INTAB data. INTAB data also shows the good control, it's only very small percentage. Interesting observation is here, around 25% of the patient in urban population. In urban population, they are getting good control. Whereas rural population, their control is not that good. Now, there lies the importance. When you look into the data again, INTAB Kerala data, we showed, I'll show you the one slide also. So, people are giving anti-diabetic. We have seen a lot of prescriptions. A standard prescription from a rural area is Dionil, Ravile Unna, Ucheki Unna, Ratri Unna, or Nalira Anjunaram. That's all. That's a usual prescription. Single tablet people are taking. That is not correct. At least you go for multiple drugs, at least 2 drugs for a starting medication for diabetic patients. What is the importance? Because basically this type 2 diabetes mellitus is a progressive disease, whatever said and done. When I was a student, we thought and I say, okay, DPP4 is coming. Now you can reduce the progression of, or the speed of progression, whatever. Nothing is happening. See, even now, diabetes is a progressive disease because of multiple risk factors or pathophysiological changes that are happening here. Now, very important message, long-term glycemic control remains very, very difficult to attain due to progressive reduction of beta cell mass. That's a very important message. And this is a conventional approach. When I was a student at Trichy Medical College, we used to go for lifestyle medication for 3 months and metformin for 3 months, Dionil for 3 months, something like that. Oh, it's a traditional approach. The problem with the traditional approach is you are maintaining or you are in uncontrolled phase of diabetes mellitus for a long time. So at least, say 3 to 4 years getting elapsed with this conventional treatment, which is not acceptable. And we have another paper, very interesting paper, we showed the diabetic aging study. So what is the meaning of legacy effect? Legacy effect means you try to get a good control of diabetes mellitus. How long? Is it for 10 years? By MD days it was 10 days and DM days it was 5 and subsequently we reduced to 2 years. But this diabetic aging study shows the first year of your diabetes mellitus, which is very, very important to get a legacy effect. So ultimately, if you get uncontrolled diabetes mellitus in the early phase of diabetes mellitus, you are not getting that good the metabolic milieu and you are likely to go for multiple complications. That's a message. So if you go for conventional treatment like non-pharmacotherapy, metformin, Dionil, something and eventually you are spending a lot of time with uncontrolled diabetes. So it's probably very, very important to maintain good glycemic control in the initial phases. When we looked into our data, these are data from INTAB data, Kerala data, we showed most of the patients, at least 40% of the patients, they're taking Dionil. Only Dionil for the management of diabetes. You may be wondering that. It's true. This is the data. Household, we went to their house and we got the data. 1 tablet of Dionil or 2 tablets of Dionil, no metformin, no non-pharmacotherapy, no other drugs. These are the ground reality. Now, coming to the data, other data shows, UKPDS data, whatever said and done, UKPDS showed if you are giving single molecule or probably multiple drug also, you can see here the failure rate after 2 years. This is from the UKPDS data. This is from ADOPT data from KIMS et al. Published in NEGM, which also showed after 1 year, the glycemic control becoming bad, and eventually they will go for complications. No, it's very important. You go for aggressive management of diabetes mellitus in the initial phases. You go for non-pharmacotherapy or you go for some other molecule. See, your aim is to get good glycemic control. Very important. Now this is a picture. You go for that, metformin, something like that, 2 drugs, 3 drugs, 4 drugs, and probably after 10 years only you are starting insulin. That is not correct. So the concept is good early control, so you will get a good durability also. There lies the importance of combination treatment. Combination treatment, I can stop here. Any combination is possible. See, certain drugs are not contraindicated, certain drugs are not, goes hand in hand, nothing like that. You can go for any combination. You can go for metformin, you can go for DPP drugs, you can go for insulin, you can go for pioglitazone, you can go for SGL2, any molecule for that matter is acceptable because that will address most of the pathophysiological changes. I still remember JMR sir was discussing a slide. Microbiota and diabetes also. Now it's a big topic, microbiota and diabetes. So people are giving multiple drugs to reduce or to address all these pathophysiological changes. That's the importance of combining multiple drugs. So early initiation of combination treatment. Is it supported? Yes, we have supportive evidence also. You have evidence-based medicine also. There are sufficient data, solid data available in the literature for starting combination treatment. One of the studies, initial study. I'm not discussing in the detail. What is shown here is a multinational study which showed the failure rate was significantly reduced in terms of fasting blood sugar and postprandial blood sugar. Everything was reduced if you go for combination. This data they were using vildagliptin and metformin, and adverse effects also significantly reduced with the combination of molecule. So the motto is just go for combination treatment. You have another data, verified data. There also they were using vildagliptin and metformin. They could document durability, beautiful durability for a long time, legacy effect, everything they could document. So it seems verified trade is a good study for giving combination of molecule. Combination in this study, verified study, was Sibilda plus metformin. So key findings you can see, number of patients with good control, more than 5 years, it was good, and time before intensification, again, see everything put together, this seems to be a very encouraging data. You can go for combination and you'll get good glycemic control, and eventually that will translate into glycemic durability also. Now coming to the other combination. You have lot of molecules available here. You have SGL2 molecule plus DPP4 molecule. All these drugs has got combination or multiple effects in multiple levels, and the glycemic efficiency is good and durability is also good. Now, Zoom work ചെയ്യുന്നൂടെ? സ്ലൈഡ് മാറുന്നില്ല. ഇവിടെ കാണുന്നുണ്ടല്ലോ, ഇവിടെ കുഴപ്പമില്ല. Okay. So if you go for combination of DPP4 and SGL2, see what's happening here. See these gliptins or DPP4 that will affect 1, 2, 3, like that, 6 out of 8 pathophysiological changes of diabetes mellitus. And if you combine this SGL2 acts in this area, this part also, so eventual reduction is good, and cardiovascular benefit is move in the motion. മൂവിലൊന്ന് വിട്ട് കഴിഞ്ഞാൽ അത് വായിച്ചോളാം. ഇത് മൂവ് ചെയ്യുന്നില്ല, അൺനോൺ എറർ ഒക്കെ ആയിട്ട്. ഏതാ? അല്ല, എനിക്കിത് കാണാൻ പറ്റുന്നില്ല. ഇവിടെയാ? Okay. Okay. So then they will ask you, say, how to start? Is it SGL2 first or DPP4? There is no significant difference at all. Either way you can give, and the glycosylated hemoglobin reduction was not very clinically significant also. So now what is shown here in this chart, if you go for SGL2 first and DPP4 drug, it seems giving better result. That's a message from here. And this type of combination you can go for any patient, maybe a fresh treatment case, and if the patient has got failure to other drugs also you can combine. And if the patient is showing evidence of drug failure or secondary drug failure, there also you can give. Now, what about the guidelines? American Diabetic Association, all the recommendations gives the information that early, aggressive and combination treatment is better for a good glycemic durability as well as for outcome. These are the data from American Diabetic Association 2023. And in addition to that, you have lot of data are being published in various literature. This is one of the literature. There also, if you go for combination treatment, glycosylated hemoglobin fasting postprandial is significantly reduced with this combination treatment. These are the data, and we have other data also. This is published in Diabetes Care Journal, which also combination of multiple drugs, including SGL2, DPP4, and metformin, gives additive effects and complementary effects, and glycosylated hemoglobin is very good. So these are multiple benefits if you combine all these three drugs. And combination of drugs will address most of the pathophysiological changes. If you are giving three drugs, SGL2, DPP4 and metformin, that will address the most of the, or 7 out of 8 the omnious octet of pathophysiological diabetes. Now, this is a Diabetes Care Journal. There also, if the patient has got high glycosylated hemoglobin defined as more than 7.5% of the glycosylated hemoglobin, you can combine. This is one Indian data which also showed combinations doing wonder in terms of glycemic efficiency, glycemic durability. So it gives a more confidence, and probably is a good step to give multiple drugs in the initial phases itself. This is the data. This is another data, Indian data, the SPACE data, which also showed the sitagliptin add-on insulin was useful. So you can go for any combination in your clinical practice. Not only glibenclamide, metformin, any combination is acceptable. Ladies and gentlemen, let me summarize my talk like this. See, you have the drugs which will address pathophysiological changes and eventual reduction of glycosylated hemoglobin, durability, and complication, both micro as well as macrovascular complication, and that will definitely translate to the reduction of complication. Thank you very much. Let me sign off. Thank you very much.
Thank you, Dr. Jabbar, for the excellent talk and finishing on time. I'm sure there will be a lot of questions and comments. I think the combination therapy, we Indians are supposed to be very good in making combination therapy. Good old days, 30 years ago, when the sulfonylurea in the glibenclamide came in 1970, Indians came out with a combination of sulfonylureas plus metformin. Then the Americans start laughing at you. What is this Indians? They are good in making combination, but they don't understand the pharmacology of the drugs. See, glibenclamide has to be given before meals, metformin given to be after meals. These fellows are giving combination together. What is this? And they are looking funny at us. And now it took about 30 years to say that combination is better. So I think Indian brains are much, much better than the Americans one, but the problem is always ADA comes first, guidelines. There is the Indian guidelines, nobody looks at it. That is a problem. And second thing is, type 2 diabetes management combination is is important, because I always tell my patients, because a combination advantage is the patient is saying, oh, I am taking only one tablet, but it may be having three chemicals in it. So that way we are able to convince the patient we are giving you the least amount of drugs. Don't worry, because side effects are much less, because only one tablet you are taking. But the thing is that I always tell them, type 2 management is managing just like a cricket match. So Tendulkar is a number one batsman. If you make an Indian team with 11 Tendulkars, Is it going to win the game? No. You have to require batsman, bowler, fielder, wicket keeper, everything. Like that, type 2 diabetes management has to take different trucks acting in different direction so that it will be able to win the game very fast. So I personally feel that is, we Indians were using it much more earlier. Now the whole world has accepted it because the compliance is the one thing which is very important. One tablet they will be able to take it. Doctor.
Thank you, Dr. Jabbar, sir, for highlighting the need for aggressive early management of diabetes because it is a dynamic metabolic disorder, and also highlighting on the legacy effect. I think it's very important. And I think now our practice is changing because the availability of information on the pathophysiology and also the the vast array of drugs available. Thank you for touching on those. The floor is open for discussion.
No, Dr. Kurian, in fact, people are not changing. What we understood from the interior part, rural area, Idiki, Wayanad and all, they're taking only dionyl. Only dionyl, no metformin. Okay, it's very common to see. Even Ernakulam district also, we have visited, personally I visited few areas in that Vaitila rural area. It's not purely rural, but there also people are taking dionyl. And the explanations are, drug is easily available.
Yes, that is the only thing. Our government is also supplying free.
No, sir, we are giving Glimepiride now in government. We are not entertaining glipin, but still they are taking only one tablet or secretocoque, nothing more. No non-pharmacotherapy, eating 1 kilo of beef and 1 kilogram of rice. That's not changing. That's a scenario of all districts. Trivandrum also same, sir. Same. People are taking only one tablet. And we have probably, sir might have seen a lot of prescription, only secretocoque. That is not good. And now, of course, see, I think teneligliptin era, people started using teneligliptin probably because of the cost factor. Now I think, tenli has gone, still people are taking only one tablet, one secretocoque.
Dr. Jabbar showed some papers saying that the control is only 30% has got good control. That is all over the world, it's like that. So now we don't feel much sorry because if you try to make them better, you will land in level because the patients have got their own vision and attitude. See, recently, IAM, Indian Institute of
Management,
Ahmedabad conducted a course for doctors how to deal with your patient because nowadays finding doctors getting so much abuse everywhere. So they conducted a course, and there is one pediatrician MD fellow who has finished his course and then joined MBA and then these are the faculty. So what advice he gave is that, see, if you are treating a short illness like pneumonia or COVID or anything, whatever you tell the patient follow, it is only 10 days or 15 days treatment, patient will become better, he will be happy to go. But those doctors who are treating chronic disease like diabetes, hypertension, cholesterol, you go on preaching them, they don't like, they go to the social media, find out information, all the side effects and the wrong thing. And they will come and ask you, and if you go and advise, you must keep your hemoglobin at less than 7 and all those things, you land in a long trouble. So what that doctor advises, that faculty advice is that when the patient comes and talks to you, you must feel his pulse, what he wants, what type of treatment he wants. He doesn't want it. You play accordingly. I'm not saying it is.
That's true.
What he said is, at the end of the day, you must feel the pulse of the patient, what he wants and all. Then you play like this. Don't try to teach him scientifically and don't make him very tight control and prevent him. See, what he wants, you do it. So then he will be in your, you will be in his good books. See, no, I am facing this now. See, I advise some people about this is very bad. See, your cholesterol and what is happening and all. They went and complained, this fellow is firing me. Even my daddy has never fired me like this. That is attitude. So the main thing is you feel the pulse of the patient and feel so you will be a very popular doctor. Then what he wants. He wants, he does not want insulin, then you address it. Then you can finally last say, if you take insulin, that will be little more better. Just very politely tell, but whatever his need is required, you worry. That is the main thing.
That's true. See, in practice.
See, this is this is the advice is for doctors how to be successful doctors in the society.
I think people are very active in social media.
It's not for the doctors how you good in you are managing diabetes. It is how you are very popular and good with the patients. You feel the pulse of the society and feel like.
I think social media is making a lot of impact and influence on public also. And they are asking, "This hemoglobin 7 മതിയോ? 6 ആയ കുഴപ്പമുണ്ടോ?" One fellow from Kottayam only, his glycosylated hemoglobin is only 6, and his age is very, very young guy, 80 only, 80 plus. Still, he wants to get a glycosylated hemoglobin of 6.5, as per the social media quoted by one fellow. So people are much bothered about glycosylated hemoglobin. They want to reduce. If he develops a hypoglycemia, you will be in trouble. അത് നമ്മൾ ആരും പറയാൻ പോകുന്നില്ല. അല്ല 80 plus ആണ് ഒരു hypoglycemia ഉണ്ട് അത് മതി. Social media is making a lot of fuss and confusion. Thank you very much.
Thank you, sir. I'd like to invite Dr. R.V. Jayakumar to present a memento to Dr. P.K. Jabbar.
Computer.
I'd like to invite Dr. C.P. Joy, Senior Physician, to present a memento to Dr. R.V. Jayakumar, and Dr. N. Sunil to present a memento to Dr. Kurian Xavier. Our next session will be ideal insulin in current scenario. I'd like to welcome the speaker, Dr. Jeevan Joseph, consultant endocrinologist in Jeevan's Diabetes and Endocrine Center, Kottayam, and chairpersons Dr. Rajesh Menon, consultant physician in Bharat Hospital, and Dr. Sadakatullah, consultant physician in KIMS Hospital.
Good morning, all. First of all, I would like to thank my co-chair for giving me this opportunity to chair this section. After that elegant talk by Dr. Jabbar about the changing concepts in oral hypoglycemic agents, that's you have to use a combination therapy. Probably you have to use a non-hypoglycemic drug first. In insulin also the situation is changing. There are newer insulins which are coming, and these newer insulins are being used more and more. So to talk about this, we have Dr. Jeevan Thomas. I give it back to Dr. Sarkar to introduce.
Good morning. Dr. Jeevan is running a diabetic institute in Kottayam, in fact a diabetic and endocrine center in Kottayam. He had done his MBBS from Alleppey Medical College, done his MD from SRMC, and he had a lot of degrees from UK, had done FRCP, MRCP, FRCP, CCT, all from UK. And he's a powerful speaker, and you can listen right now.
Thank you very much to all the faculties here, chairpersons and friends. Having organized quite a few of these CMEs myself, I'm quite aware of the effort that my good friend Sadak has taken to do this, and I congratulate him first for this excellent CME. I think I will go straight to the topic. The topic is essentially ideal insulin in the current scenario. So what is the current scenario? The current scenario, as the previous speaker has kind of elucidated, is that you have a huge spectrum of agents to choose from. And there's all these new drugs and injections. You have SGLT2s, you have the once weekly GLP-1s, you have the oral GLP-1s. So there's a usual query as to what is the role for insulin, or does insulin continue to have a role, and if so, what is that role? So that is the real query that we are addressing, because we're all focused on preventing heart attacks and using this drug for preventing renal failure and all the rest of it. Sometimes we do lose a little bit of focus about the basics itself. And the basics really is that you have to be glucocentric before you do anything else. And you can see here from the DCCT study that as your control goes higher, as denoted by your HbA1c, all your complications, whether it's microvascular, macrovascular, whatever it is, it keeps going up. So you can't forget the fact that you need good glycemic control. And if a patient asks you, if I do everything that you say and I have good glycemic control, what will I gain? The answer is very clear. You'll gain about 15 years of complication-free living. And maybe if you do all the other things like take your statins, control your blood pressure, multifactorial intervention, you will gain 8 years more of your life. That is what the STENO-2 trial shows. So you can get 8 to 10 years of good complication-free life if you have good control of your diabetes. There's no doubt that if your HbA1c begins to go high, then both your myocardial infarction rates, your macrovascular complication rates, your microvascular disease rates, all of this goes high. We know all of this from the UKPDS study. Even in patients who come acutely unwell to hospital, if you look at mortality of diabetes patients undergoing CABG, you can see that if their blood sugar levels are high, then your mortality levels are high. You can argue whether it is an association or a causation. That's a different question. But clearly they seem to select out, high glycemia seems to select out a poorly performing patient even in acute settings. So surgical ICU mortality is higher if your blood sugars are high. If you look at overall hospital mortality and hyperglycemia, that is high if your blood sugars are high. So if you have a patient in your ICU running a high blood sugar, that is a good marker that this patient is not going to do as well as somebody who is having good control of diabetes. So there comes the role of insulin. So because I'm just trying to set the stage amongst all these agents as to what is the role for insulin in our continuing management of diabetes. So it is the most powerful agent that we have to control glucose. All of us recognize this. And the miracle of insulin, you can see yourself. I would say that insulin is in the same pedestal in terms of discovery as penicillin. So this is the same, the first boy who received insulin and what he was before and what he got. And when you have all this social media about alternative medicine, we tend to forget that 100 years before, if you had type 1 diabetes, it was a death sentence. And we tend to forget that. And so I think we should be proud in modern medicine of what insulin has achieved. We also have data like this. So when you have so much data about insulin, some people ask, why don't I start insulin from day one? Is there any advantage to doing that? I'm sure you have some patients who come and ask you that question. So the Origin trial looked at this, who are newly diagnosed with diabetes. Some patients were straight away put on Glargine. And they followed up these patients for 6 years. The others received standard therapy. Whatever the doctor wanted them to do, they did. They actually found that there was no great advantage in terms of cardiovascular benefits by starting Glargine at the start. So a valid question can be asked as to when should insulin be started, because if insulin is perfect, then we should start it on day one. But there are some data that is not actually required. So the question is when to use insulin, and there are clear guidelines, and I've just, kind of summarized it. So essentially, if you have ketotic symptoms, if you are losing a lot of weight, looking unwell, you need to be on insulin. If your HbA1c is greater than 10%, you need to be on insulin. If your fasting blood sugars are greater than 300, then that is a good indication that you need insulin for some period of time. In organ dysfunction and failure, we always rely on insulin. In acute medical emergencies, MI, sepsis, in ICU, and HDU and things, we rely on insulin. Diabetes in pregnancy, most people would use insulin. If you have complications of diabetes like sarcopenia, diabetic amyotrophy, autonomic dysfunction, gastric dysmotility, then sometimes insulin is quite good. If you want rapid control, maybe preoperatively or perioperatively, then you have nothing else other than insulin to use. And also if you are using diabetogenic medications like high doses of corticosteroids for whatever other reason, the patient has to be on high doses of steroids, then you have to use insulin to get good glycemic control. So that is the real role for insulin in the current setting. And there is no ideal insulin that will fit for any of these. You have to choose the insulin depending on what is the situation. For type 1 diabetes, there is no question. We all know that in type 1 diabetes, there is a rapid decline of the beta cells. And if you don't give the patient insulin, you land up in trouble. So if you have a youngster coming to you looking lean, blood sugars are running at around 400, first detection of diabetes, you have to be careful. And sometimes until you can work out things, the safest option is to give him a little bit of insulin. And that's what I generally say. You start insulin, and then later on when things are clearer, I'll decide whether you need to be on insulin or not. So we all know that for type 1 diabetes, we need to use insulin. What is the ideal therapy? Multiple injections with analogs and basal insulin, or what is called basal bolus therapy, is the best treatment that you can give to a young type 1 diabetic, because they have to have a flexible lifestyle, and they can't be locked on to timings in terms of when they can inject and all the rest of it. And we know that there's a lot of evidence for using a basal bolus therapy. If the patient is able to afford it, insulin pump is a improvement on the basal bolus therapy, and some patients, and especially type 1 diabetics patients, tend to do better if they can do an insulin pump. The other things I will not discuss further because they're not really available to the large number of population in India. Type 2 diabetes, over time, most patients will require insulin. We know from the UKpedia study that at the end of 10 years, 50% of patients with type 2 diabetes went on to insulin. So it is something that will have to be used in a number of patients. What are the types of insulins you have? You have the ultra short acting, the rapid acting, the short acting, the intermediate acting. You have glargine, which I think almost all of you would have used, and you have the ultra long acting insulins as well now, Degludec and the U300 glargine. So you have a huge spectrum of insulins to choose from. And again, there is no ideal insulin. Every insulin will be ideal for that particular patient in that particular scenario. So all the clever pharmacological advances have made sure that by either suspending them as multi-hexamers or dihexamers or dimers, you can actually cut short the period or lengthen the period during which an insulin will act. And that gives you these ultra long acting insulins. It also gives you the ultra short acting insulins. So if you compare insulin aspart and lispro, which are the short-acting insulins that are very commonly and widely used, with a regular human insulin, you can see that because of the dissociation patterns that are different, you can get rapid action from the analogs. So you can see here the broken line is the short-acting analogs, and the other one is the regular insulin or Actrapid or whatever we've used for some time. And you can see that the first peak of insulin release is very quick if you use the short-acting insulin. So that's what happens in the normal situation. If you take a high carbohydrate meal, the first phase of insulin response in somebody whose pancreas is working well is very rapid to actually control the, and we are trying to recreate that by using the ultra short-acting or the short-acting insulins. If you look at the long-acting insulins, comparisons of glargine with NPH, you can see that glargines are much more flatter insulin, and NPH really is not a 24-hour insulin. If you're going to use NPH, you have to basically use it twice a day to get good glycemic control. So this is what we are trying to do when we use insulin, try to mimic the physiological pattern of rapid-acting insulin before every meal and the long-acting insulin, which will give the basal coverage. So this is the basal bolus insulin therapy that would be one of the key ways in which you can deliver insulin, especially in inpatient settings in type 1 diabetes. and so on and so forth. So if you want to start somebody on a multiple drug injections, how do you actually do it? So it's basically based on weight, and this is what I tend to do. I tend to look at their weight and take half of it, and I split it so that about 40% of that would be the basal rate, and the rest would be split into 3 equal short-acting this thing. So it's very simple. So if you have somebody who's 70 kilograms, so it's about 35 units of insulin that this person will require. 20% of that will be the starting dose at every meal, so that will be about 7 units, and about 40% will be the dose at bedtime, that is about 14 units. So it's a reasonable ballpark figure to start off with, and sometimes the reason why we don't get good control is we don't give them the actual amount of insulin that they need. So patient goes for many months without poor control, because the patient may not come back to you till 3 months, and the patient may be on 4 units 3 times a day and 6 units at night, and is walking around with poor control, and the patient gets an impression that the insulin is not working or this is not a good treatment, because they don't see the improvement in their in their glycemic control. So there's lots of reasons why to use basal bolus, but certainly in the inpatient settings, I know that there are many residents here, so that's why I included this slide. So the RABBIT-2 trial is a very good trial which compared sliding scale versus basal bolus therapy in inpatients. And it's very simple how they started. So this is, I think, something that we can recreate, because somebody comes to ICU, you don't know what is happening. They are on various medications. So how much insulin to start? So what they did is they stopped all their anti-diabetic drugs. If their starting random blood sugar was between 140 and 200, the amount of insulin was calculated 0.4 units. If it was above 200, it's 0.5 units, basically half their body weight. And they split it into 50% is the bolus component and 50% is the basal component. So 30 units, 15 units is glargine, and the rest 15 units is split into 5, 5 and 5 of rapid acting insulin. So that's what they converted these people to, and they compared them against the sliding scale regime. So if you see here, the sliding scale regime causes persistent hyperglycemia because you're always trying to catch up, and it never gives you good glycemic control. So please do not use sliding scale therapy in patients. You should use basal bolus therapy with correction. So some patients will require some amount of correction based on how high or their hyperglycemia is. So that is what the RABBIT trial showed us. Now, if you want OP settings, how to start insulin in OP settings, what do we start? And we have various options in India. So basal insulin is what many of us are very comfortable with, because it's only one injection, safe and simple to use, and it has only a low dosage requirement. In the Indian setting, we know that our carbohydrate content in our meals is quite high. So the basal insulin, most of the trials actually come from the Caucasian population where they don't have that much of a carbohydrate load. So in the Indian setting, it's quite likely that you can go for the mixed insulins as well. So you can have a 50-50 mix in the morning and a 30-70 mix in the evening. That's a quite good way of giving good coverage with some control for the postprandials. Or if you wanted to recreate a basal bolus regime by giving only 3 injections with 1 pen, you can give the 50-50 mix 3 times a day. There are quite a few data to show that the 50-50 mix 3 times a day is roughly equivalent to the basal bolus regime, with the added advantage that you need only 1 pen and only 1 delivery device for the patient. So, and it's more simpler as well for the patient rather than having both the short acting and the long acting. So these are all Indian kind of solutions to what is a complex problem. So if people ask what is the ideal basal insulin to use, should we use only analogs? Should we not use our old NPH and Insulatard and those kind of insulin? There's a trial that has looked at it. And again, a very simple trial. They gave 10 units of basal insulin at bedtime to those people who are already on OHAs. And they titrated the basal insulin to get a good fasting blood sugar of less than 100. So this is a trial done in UK actually, treat to target study. And they actually found that both the patients, both groups, whether they were on NPH or whether they were on basal insulin, they both achieved good glycemic control. The only difference was in the hypoglycemia rate. So hypoglycemia rate was lower in the glargine group and was higher in the NPH group. So potentially if you have a patient for whom cost is an issue, there is no harm in using NPH insulin as your initial insulin to start off with. And if they do have hypoglycemia, you can always switch them to analogs. So it's not necessary that you have to always use analogs when you use basal insulins. Some patients are worried about taking insulin at bedtime. they always are worried about hypoglycemia. So suppose if you want to start somebody on basal insulin and the patient asks, why can I take it after breakfast? So there is some evidence to support that as well. Actually, this trial which compared morning glargine versus bedtime glargine versus bedtime NPH. Actually, it found that the morning glargine was actually quite good in controlling the HbA1c. In fact, it was better than giving the glargine at bedtime as well. So sometimes patients are worried because they don't want to take insulin before they go to bed because they've had a hypoglycemic episode or they've known somebody who's had a hypoglycemic episode. So in those patients, you can get them on your side by saying, okay, no problem, you take glargine after breakfast in the morning. And you do have some evidence to support you on that. So I think I've touched on a lot of this. So you have all these kind of different insulins that you can use. And you have the mixed insulins, and you have this combination of insulin degludec with liraglutide, which is sultofi. Personally, I tend to use it quite a bit. I have probably about 40 or 50 patients on it who do very well. So in the right patients, it's very good. You have the higher strength insulins, the U300 glargine and the ultra long acting ones, and so on and so forth. So I will just touch one slide on some of these newer ones. So the faster acting aspart, or some of you must have heard of it, called FIASP. What is the role of FIASP and how does it compare to the normal aspart, which is Novorapid that most of us know. So in type 1 diabetes, there is some advantage to using FIASP over Novorapid because it's a much rapid acting insulin. The other advantage is that you can give it up to 20 minutes after the meal. So if you have a child where you are not sure whether the child or the parent is not sure that the child is going to eat, or the child may decide to eat and may take one mouthful and then refuse to eat. So here FIASP is very useful because you can give it after the child has had the meal because you don't have to predict how much the child is going to eat. So in type 1 diabetes, it has an advantage. In type 2 diabetes, there is really nothing much to choose. If you're happy with Novorapid, you can use that. I tend to use FIASP because it's actually more cost effective than Novorapid. So, there's no harm in using it. The patient's actually getting some benefit. Apidra is another insulin that we tend to use. Glulysin, again, short-acting insulin. It's the only zinc-free rapid-acting insulin and is quite fast-acting as well, and cost-wise it is very cost-effective or slightly more cost-effective than the other versions of the rapid-acting insulin. So that is something that you can use, with the if you want to prefer rapid-acting insulins. The U300 Toujeo is the U300 insulin. Again, a more concentrated version of the glargine. There is some evidence that it actually has some advantage in terms of nocturnal hypoglycemia. Although when you see the percentages, you will think that these are big numbers. The actual, in terms of actual hard numbers, they are actually small numbers. And potentially, you could say that they are still important because one severe hypoglycemia is as good as, for that patient, is a very significant event. Although, if you look at it, in a statistical sense, you will say that that is only one episode. But for that patient, it is actually a very important event. Now, there are co-formulations. There's one co-formulation which is a combination of aspart and degludec, which is actually a good agent for using in patients when you want to start off with one injection and then you will then intensify with the same. So this is Rhizodec, which is the agent which combines aspart with degludec, and you can use it with the major meal of the day once in the morning or once in the afternoon, whichever is the major big carbohydrate load of the day. And then later on, if the patient's becoming more uncontrolled, you can intensify. So these are all the kind of newer insulins that are currently available to us and we can use. Now, if I were to become a diabetic, then I don't want to inject myself every day. Instead of 365 injections, if I can get out of that and do just 52 injections a day, that would be great. So you don't have to wait long. You just have to delay your diabetes by another couple of years. By 2025, we will have the once weekly injection. So you have to only inject once a week and it will cover you for the whole week. So this is already in early stages of being rolled out commercially. And the company says that it will be launched in India by mid-2025. So if you are pre-diabetic now, please hold on for another couple of years. And you'll have, this is the comparison with glargine, shows that it's as good as glargine, in fact superior to glargine, daily injections. So, and there are trials going on where this is being combined with injectable semaglutide. So you will have one injection which will have a weekly GLP-1 agent and a weekly insulin. So one single shot for the whole week, which will cover most of the pathophysiology of diabetes, and you can take a little bit of metformin and one injection a week, and that's it. And I suspect that you will be able to maintain good glycemic control for at least 8 to 9 years on that particular therapy. So all that is coming. We can't finish off any talk on insulin without just mentioning insulin pumps. So there are lots of these insulin pumps around, but the one that is most commonly used in India is the Medtronic version of it. It's really useful for people with type 1 diabetes, and the real indications are people with type 1 diabetes who have disabling hypoglycemia, or people with type 1 diabetes who have poor control in spite of doing everything else, including MDIs, carbohydrate counting, whatever you have. So in these patients, it's a very good agent to use, especially in children more than 10 to 12 years is where we've used pumps. And most of the latest pumps, which is the 780G pump, is actually almost 70% automation. So it has the sensor and it has the pump, and they will talk to each other. The pump has an algorithm, inbuilt algorithm, on the basis of which it will keep correcting. So it will sense that your blood sugars are going to go low or your blood sugars are going to go high, and it will itself change the insulin delivery to actually address that problem. So almost 70% is done by the pump, and only 30% is done by the patient. Basically, they have to just put in how much carbs they are eating. And we've recently we started this on a 10-year-old girl. Fantastic results. After 1 week, all her blood sugars were between 100 to 110 milligrams per deciliter, and that girl has picked up the pump so well that the parents don't have any input. She knows all the buttons of the pump and what to do and how to download and do everything. So she only does everything, and she's done very well. So there are patients who do very well on the pump. So if you have people who have type 1 diabetes, poor control, you have to offer them. They may or may not be able to access that therapy. That's a completely different question, but they should have the knowledge that such a therapy exists. So I think I will just summarize now by saying the question asked to me was, what is the ideal insulin in the current scenario? And the answer really is that the ideal insulin will depend upon the glycemic parameters, the risk of hypoglycemia for that particular patient. If somebody is a painter working at heights, or a taxi driver or a bus driver, I treat them differently to somebody who is just doing a sedentary job, because the problems of hypoglycemia for that particular person is much higher than some guy who is sitting in the office and pushing a few files. So the risk of hypoglycemia has to be assessed for those for deciding the type of insulin. The setting, whether it's OP, IP, emergency, makes a difference. The preference of the patient. So you may want to give basal bolus, but the patients are not willing to take basal bolus. He is only willing to inject it twice a day. So you have to take that into account. And you also have to take into account the cost effectiveness. So the older insulins are quite good. There's no reason to use analogs in everybody. But in those patients where it is required, we should be able to use them as well. So that is how we will choose what is the ideal insulin in the current scenario. Thank you very much.
Thank you, Dr. Jeevan. He has covered all the newer insulins, their advantages, and what situation to use them for. The topic is open for debate. For questions.
Starting with insulin, chronic settings are in elaborated on sleep. That's good. I have one doubt. How does this insulin be helpful in diabetic amyotrophy? I'm hearing the first time. How does it be helpful, sir? Yeah, so one of the reasons why you have diabetic amyotrophy is, the large fluctuations that you have in terms of your diabetes control. And also, you can also have a lot of issues with regards to the nervous involvement in that kind of setting. So most of the evidence for use of insulin is that in these kind of neuropathic kind of settings, where there is an element of the nerve involvement, the fact that you can actually keep your insulin levels stable within a reasonable period of, within a reasonable band, say between 70 to 180 milligrams, by use of an agent which does not cause additional fluctuation, is quite useful. So this is useful in gastric dysmotility, can be useful in diabetic amyotrophy, can be useful in actually very severe peripheral neuropathies. So in these kind of settings, it is not the exact level per se, but it's the huge fluctuations that actually make things worse. And if you can use insulin with insulin, you can give small titrations that are not possible with tablets. So if you use tablets, you've taken 1 milligram of glimepiride in the morning. Now what will you do? You can't do anything until you come to the evening. Whereas if you have insulin, you have a mechanism by which you can titrate up or down to keep your blood sugars stable within, say, 80 to 180 milligrams through most of the day. And that can help you with some of these very intractable problems. So it's not an easy problem to treat. And also very severe peripheral neuropathy is also not a very difficult problem to treat. Some people who have gastric dysmotility, autonomic dysfunction, these are all problems which don't have one single solution. And keeping the blood sugar stable within a range is quite good as one of the therapies for it. Certainly during that period it is indicated. Throughout the life, it depends on other factors as well. So if the patient is willing to do it, there's nothing wrong in continuing with insulin if you have achieved something good by using that insulin therapy. So there's no requirement to stop it, as it were, because it's not like an antibiotic that you have to use it only during that period and then you have to stop.
Thank you, Dr. Jeevan.
Inviting Dr. Sadakatullah to present a memento to Dr. Jeevan Joseph. I'd like to invite Dr. Professor Hanif, Senior Physician and HOD in KIMS, to present a memento to Dr. Rajesh Menon and Dr. Sadakatullah, sir.
Slide open.
The next session will be hypothyroidism. The next session will be hypothyroidism in pregnancy. I'd like to welcome the speaker, Dr. Sadakatullah, consultant physician in KIMS Hospital, Kottayam, and chairpersons, Dr. Raju R. Nair, who is the head and director of the fertility department in Mitera, and also the president of the Kottayam OG Society, and chairperson, Dr. Rajib Muhammad, consultant physician in Bharat Hospital, Kottayam.
Seems very sure.
Good afternoon, everybody. We are reaching the penultimate session of the day. And this definitely shows what all roles Sadakat has to take. Just a moment before, he was the chairperson here, and now he's there on the podium, and he's also running the show. The topic for discussion is hypothyroidism in pregnancy. We know that the normal thyroid hormone levels or a euthyroid state is a very essential thing for pregnancy to occur and for the normal culmination of the event. And there are several factors which can produce changes in the thyroid hormone levels, maybe the interaction of human chorionic gonadotropin or estrogens producing a normal change, as well as other pathological conditions. And there are definitely questions always raised by the gynecologists, like as to what should be the level of thyroid hormones and what would be the normal level and this and that. And of course, there are the guidelines set also for us to be maintaining that. So to elucidate on all these topics, we have Dr. Sadakatullah, and he invite you to deliver the lecture.
വന്നില്ല കേട്ടോ, അല്ല അതല്ല, ഇതിൽ വന്നില്ല. അത് ഓപ്പൺ ആവുന്നില്ലല്ലോ. ഏതാ എന്നാ സാറേ വേണ്ട 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 തർച്ചോയാ എവിടെ നിന്നാണ് എവിടെ നിന്നാ സാധനം റീസെറ്റോ ക്ലോസ് ചെയ്തേ അല്ല സാറേ അത് ഓണായോ
ഓണായിട്ടില്ല വിളിക്കണം
വിളിച്ച് വിളിച്ചോ ഇതിൻ്റെ ആളെ വിളിക്കോ പ്രൊജക്ടർ ഓഫായിരിക്കുക പവറില്ല പവർ ഓഫായി
ഇതൊന്ന് റീസ്റ്റാർട്ട് ചെയ്യാമേ ഉണ്ടോ എൻ്റെ ലാപ്ടോപ്പ്
വേണ്ട Good afternoon to all. We had two powerful session from the two endocrinologists. You had on diabetes, two segments are there. Now the next topic is again an endocrinology topic, but it is discussed by a physician only. So it will be on the physician's level only we will be discussing. Okay. In fact, hypothyroidism is a second commonest endocrine disorder which is seen in the pregnancy. First, of course, you know the diabetes, gestational diabetes mellitus. It is in fact always a controversial and debatable topic. I'll be discussing the topic a little bit about the physiology of thyroid hormone and what changes, what hormonal changes that is happening in pregnancy, and what is the target of thyroid stimulating hormones level during pregnancy, and something about the management of pregnancy. This is what normally you see. The hypothalamus, this is hypothalamus-pituitary axis. Hypothalamus will be producing TRH, which acts on the anterior pituitary. Then from the anterior pituitary you will get a thyroid stimulating hormone which acts on the thyroid gland, which will produce free T3 and free T4 into the circulation. Then always there is a negative feedback is there. Whenever there is a high level of T3 and T4 in the circulation, that sends a signal back to the hypothalamus and pituitary, say no more secretion of the TSH. That is what normally happens. So, what changes that is happening in the pregnancy? Pregnancy always, it is a hypermetabolic stage where you need more of an energy. Basal metabolism is more of thyroid hormones are required. Your requirement is like 20 to 25% higher than the normal level. Basically, in the pregnant lady, the two hormones are playing a major role. One is HCG, which is secreted from the corpus luteum of the placenta, and another is the estrogen. When HCG is it's a glycoprotein which has got an alpha and beta subunit. The alpha subunit has got a structural similarity with alpha unit has got a structural similarity with the FSH, LH and thyroid stimulating hormone. So it acts like a thyroid hormones. When HCG is more, what will happen is it stimulates the thyroid gland to produce more of a T3 and T4 into the circulation. When more of T3 and T4 in the circulation, what will happen? What we mentioned earlier, there is a negative feedback. You will get a low TSH. That is why pregnancy, why you get a low TSH, why you want to put the target lower down, because when the HCG is more, the TSH will be less. That is one thing. Second thing happening is there's a lot of estrogens are there throughout the pregnancy. The estrogen will act on the liver to produce more of a thyroid binding globulin. When the thyroid binding globulins are more, what will happen? Whatever the free T3, free T4 in the circulation, this will go and bind to the T3 and T4 in the circulation. Ultimately, what will happen is free hormones are less in the circulation. So these are the two things are happening. And the third thing is happening is if you are in an area like in a hilly area where iodine contents are less in their because of the habits. Now we don't have a problem because we are all getting the iodide salt. In pregnancy, the blood flow to the renal arteries are much more. So glomerular filtration rates are more in pregnancy. Then the more of thyroid hormones are, because of the increased GFR, eliminated through the circulation. So you require around 150 microgram more of iodine in your blood. So these are the basic changes that is happening. So the HCG will increase the thyroid function. When the thyroid T3 and T4 is elevated, see. When T3 and T4 is elevated, TSH naturally comes down. That is the one thing. Then hyperestrogenism, there's an increased thyroid binding globulins are there. Okay. This is a very important slide. The first trimester of pregnancy, the HCG goes up. When somebody is having a hyperemesis gravidarum, HCG levels are much, much higher. Then there's a reciprocal things happen in the thyroid TSH, it will come down. There are a situation where you can get a transient hyperthyroidism also when there's a patient is having a hyperemesis gravidarum. Okay. But that HCG level comes back to normal by around 12 weeks of gestation, and again the TSH also comes back. So when you want to evaluate the patient about the thyroid hormone, in the first trimester, if you get a very low value, that means that is the period, the first trimester is the period the organogenesis happens. When the organogenesis happens, you need to supply sufficient amount of thyroid hormone because your basic metabolic rate is very high. That is why somebody comes, a pre-pregnant patient who is having a hypothyroidism, when they become pregnant, we know there is a requirement of the thyroid hormones are more. What usually I does is give a double dose, whatever they were taking in the weekends, Saturday and Sunday. Suppose somebody is on 100 micrograms of a thyroid hormone, thyroxine they were taking, the 20 to 25% of amount of thyroid hormones are additionally required for these people. So what I ask is take the 2 tablets on Saturday and Sunday, then continue the same thing. There are people who comes with I forgot to take the thyroid hormones today morning, take it in the afternoon. If they miss it, the next day they take 2 tablets. Because this has got a mechanism is like that, whatever you need is 1 week, whatever you require, you can supply. Even if you want, you can give whole sort of thyroid hormone for a week, they can take in a day. So there is no issue at all. So you can double the dose. This is what the hormonal changes happening is. Okay. This is what during the consumption you see the first 12 weeks. Up to the 12 weeks, you need 100% supply of thyroxine for the baby because baby's thyroid gland starts developing only by 12 weeks and sufficient amount of hormone is produced only by 20 weeks. Till 20 weeks, you need to supply with the thyroxine for these people. So this is what usually happens is this is the HCG. Okay, when HCG is going up by 10 weeks, HCG level goes up and gradually comes down. So Opposite thing is happening is when HCG goes up, the thyroid hormones comes down. This is the, and another thing is this is what is you are showing is a thyroid globulin. Thyroid globulin level also increases throughout the pregnancy. It will be remain high throughout the pregnancy. Along with that also, thyroxine level also goes up. This is a not the free thyroxine. There's a combined thyroxine or a thyroxine bound thyroxines are elevated. This is what is happening in pregnancy. Okay. So finally, what is the increased estrogen will produce 2 to 3 times fold increase in thyroid binding globulin. A structural similarity with the HCG will produce an increased amount of the T3, T4 levels are increased, transient hypothyroidism. This is what is important. You know, the demand, due to all those things, the demand of thyroxine will be increased throughout the pregnancy. Now, what is the prevalence of hypothyroidism? Prevalence, you know, what is you are taking as a cutoff point, that is the prevalence. If you take a cutoff point as a 4.5, that's usually you say 0.5 to 5 or 0.5 to 4.5, you take it as a normal people. If you take that as a cutoff point, the prevalence of hypothyroidism are 15.1. If you are taking bringing down the TSH value to 2.5, the prevalence goes up. So it's a huge problem. So whatever the cutoff value you are taking, is there any recommendation for a universal screening for these people? Somebody comes with all the diabetic, all the patients become pregnant. It's whether you want to do it thyroid stimulating hormone level. There is no universal recommendation, is not there. There what we do is what had been practiced, high risk people, people above the age of 30. Patient had undergone a thyroid surgery, patient had undergone a radiation or something, patient had a miscarriage, like autoimmune, other autoimmune disease, type 1 diabetes. These are the people which was recommended by the American Thyroid Society. But what the Indian guidelines says, all pregnant females should be screened in the first trimester for measuring the TSH level. So this is what we are supposed to follow. Because in USA, if you want to do a thyroid, what we are supposed to follow. Because in USA, if you want to do a thyroid stimulating hormones level, they may be very expensive. So that may be the reason they are put a criteria, high-risk people, so these are the people who should be undergone a thyroid stimulating hormone estimations. Okay. So our guideline is, anybody comes into the antenatal department, do a TSH value. So what are the complications you are anticipated if you don't treat a subclinical hypothyroidism? They can have problems with both the mother and the fetus. Both can happen. So mother can have anemia can be there, pregnancy-induced hypertension, miscarriage can be there, frequent abortions can be there, hypertension in the pregnancy is very important. There's an increased risk of, increase may not be the risk, LSES can be very much high. Okay. But the problem is here, whether the neurocognitive impairment, whether that can be corrected, that is the area of a debate is there. Okay. If you manage the patient's good control of hypothyroidism early in the pregnancy, whether the other things can be improved, whether the neurological complication, that was in the recent 3 randomized trials has come in the last 1 decade, that doesn't prove the beneficial effect of a neurological improvement. But in the past, it is like the patient's IQ, the 7-point IQ improvement, it was shown when somebody was treated, or there are people who like a hyperactive child, neurocognitive impairment. These are all, traditionally it was taught that there is an improvement of these problems if you treat sufficiently this patient with a subclinical hypothyroidism. Okay. This is the thyroid problems. By the 8th week of gestation, the thyroid receptors appears in the baby. So that is the time receptors only appear, but you have to substitute the baby these are up to 12 weeks. The organogenesis is there. The baby doesn't produce a thyroid hormone, but by 18 weeks, a sufficient amount of thyroxine is there. Mind, the TSH doesn't crosses the placenta, TRH doesn't crosses the placenta, only thyroxine will crosses the placenta. Okay, but by 20 weeks, they will take care of their own problems taken care by the baby, because baby, unless like a cretin child, basically thyroid hormone productions are low in these people, they may suffer. Otherwise, normal people, the thyroxine, whatever require for the mother, baby, the baby will take care of themselves. So now, what is the target? You see, when to treat. Because these are those always physicians gets a reference from a gynecologist. The TSH value is 5, TSH value is 6. What to do and all. Okay, there are clear-cut guidelines are there. But this is the guideline around 2017 only. Okay, ITS Indian Thyroid Society says first trimester keep the TSH 2.5, second trimester 3, and third trimester 3. Okay. European Thyroid Society also goes the same thing. But what happened is that American Thyroid Society has come out with a different explanation. Are we treating these people unnecessarily, or are we over-treating these people? What they said is, take a locally available, like a prevalence in Kottayam, how many people is having taken a group of people, their average TSH value in these people. That is what. So locally derived reference ranges are there. If you are not getting a localized reference range, upper limit of the cutoff is 4. That is what the American guideline, American Thyroid Association is giving 4. Okay. So guidelines all comes, it's 4. But what Indian guidelines is keep this 2.5, 3, 3.3. Even in Gujarat and all, there are some places in India, they have taken their own, like American guidelines, their own criteria of or prevalence of thyroid hormones they have taken. Okay. Now the problem, whether to treat. When you say subclinical hypothyroidism, you can see the TSH is elevated, T3 and T4 are within normal limit. When you say overt hypothyroidism, the TSH is elevated, T3 and T4 is low. This segment of people, definitely they require treatment, there is no doubt. This is the gray area where what to do, that we will see. What Indian guidelines says, you should treat as subclinical hypothyroidism. Subclinical hypothyroidism has been shown to be associated with an adverse outcome for both mother and the fetus and should be treated with the thyroxine. That is the Indian guideline. Okay. This is the one study which is showing the beneficial or subclinical thyroidism Indian pregnant woman affects the maternal and fetal outcome. You see, this is one subclinical hypothyroidism. There is an increased incidence of anemia, increased incidence of PAH, and IUGR, IUD. Many are there. I am not showing all these things, but there is a problem if you don't treat subclinical hypothyroidism. That is an Indian study is showing. Okay, this is what. Definitely, those with the overt hypothyroidism, there is a very high incidence of pregnancy-induced hypertension, IUGR, IUD. There is definitely all 3 are there, and many more are there. Okay, so overt hypothyroidism you should treat. Subclinical hypothyroidism also found to have the beneficial effect in anemia, pregnancy-induced hypertension. There are all the higher risks are there. This is the only situation what we come across in your clinical practice. only this combination. If you see a thyroxine TSH levels are elevated, you can have a TSH elevated, free T4 down. That means you are dealing with a primary hypothyroidism. It is overt hypothyroidism. This is no question. The problem is in the thyroid gland. Second situation is the TSH is elevated, T4 is normal. You are dealing with a subclinical hypothyroidism. If you find a patient with TSH is low, T3, T4 is low, you think of a problem is in the higher up. It is in the pituitary or in the hypothalamus. So it's a central cause. So if you see a patient with a hypothyroidism, T3, T4 low, TSH is low, it is not the primary hypothyroidism. It's a problem is in the pituitary. Okay. So here also what you have to do is you think of other hormone which was producing from the anterior pituitary. You have to look for, like the may require a substitution with the testosterone, the FSH, LH, prolactin, all will be low in this situation. So that is what all is the situation. So now you are diagnosed as a case of a overt hypothyroidism. Usually what happened is somebody with an overt hypothyroidism, T3 may be, TSH may be 7 or 8. T3 and T4 is slightly low. That means they are overt hypothyroidism. They should be treated with a full dose. Not like starting with a 12.5, 25, because TSH is only 7, only 8. It is not like that. If you find that the patient is overt hypothyroidism, they should be treated with a dose of minimum 1.6. Like a 50 kg lady, they may require minimum 75 to 100, depends upon the weight. And the full replacement dose should be given, because you cannot wait, because that is the time the patient's organism, all the complications sets in, then you increase 25. Don't do like that thing. That is the recommendation. You do a full replacement dose. Whatever the guidelines are given, that is fully for the diagnosis. There is a difference between Indian guideline and American guidelines are there. But for the target, they all recommend you keep in the first trimester 2.5, second trimester less than 3, third trimester less than. This should be the target. And somebody pre-pregnant, I already mentioned, there you should increase the dose by 20 to 25% to these people. By the time baby delivered, you immediately reduce to the pre-pregnant level. Say, suppose the patient had 100 microgram they were taking, and you have increased, and the weekend 2 tablets were increased. At the end of after the delivery, you reduce the dose to the pre-pregnant level. That's the only time why you supplied it. The demand was more during that time. So this is the recommendation, upper limit of the normal. Okay, 1 to 1.5. Always is like a 1.7 TSH level is there. You not based on your own calculation. You calculate based on the recommendation like 1.6, 1.71. Suppose the patient is having a subclinical hypothyroidism, you can start with a 1 microgram. Say 50 kg lady, you can start with a 50 microgram. But don't like a 12.5, 25. Like that, they should not be done. And what should be done? You have to test like every visit, maybe once a month you can do, or once in 6 weeks you have to do. This is the recommendation also. Should be tested 6 weeks to appropriate adjustment, because there is a problem. Even whenever you are treating, the patient, hyperthyroidism is not a cup of coffee for the physicians. It has to be sent to the endocrinologist, because because drug treatment, so many complications can happen in hyperthyroidism. So when you treat the patient, sometimes there's a fluctuation can happen. Patient may go into hyperthyroidism also. So regularly you check the patients. Okay. This is I'm coming to the, due to lack of time, I'm finishing soon, okay? This guideline, if you should remember. Somebody with a TSH of more than 10, no question, that is a overt hypothyroidism, that should be treated with a full dose. On the other end of the spectrum, somebody with a TSH value less than 2.5, no treatment. The problem is, this is the area. The patient with a TSH between 4 and 10, somebody comes to you. Here, always you test for the anti-TPO antibody in these people. Somebody with a TSH value more than 4, less than 10, you should do anti-TPO. Then the next treatment is based on your anti-TPO positive or negativity. Okay. When anti-TPO, if you got a value of 5, suppose, and the anti-TPO is positive, there is no question that patient should be treated. Because the Hashimoto's thyroiditis, the autoimmune thyroiditis is the commonest cause of hypothyroidism in pregnancy. If the patient is having an anti-TPO antibody positivity, that patient should be treated. If the patient's, this is a recommendation, is anti-TPO 4 to 10 and anti-TPO negative, there is a weak recommendation is there, you can treat it. If the patient had a miscarriage, patient may be on a IVF therapy, or a high-risk patient, here again you can treat it. You can consider, just like you consider treating. But this is a definite. Okay. Now, this is again the area between 2.5 and 4. That patient's anti-TPO negative, no treatment. Anti-TPO positive, then you look into the patient, what is their risk of the patient? Whether the patient had any previous autoimmune diseases, previous miscarriage, or it's a precious baby, something like that, or a patient is having an IVF or something, that patient should be treated. So this is the guideline. So American Thyroid Society has come out with this guideline. High-risk woman, check the TSH as soon as the pregnancy is confirmed. TPO antibody if TSH is between 2.5 to 10. This is the ATA guideline, American Thyroid Society. Between 2.5, anti-TPO positivity, TSH 2.4. Here you consider therapy means depends upon the risk of the patient. Between 4 to 10, there is no question you should treat the patient. If TPO negative, 2.5 to 4, no treatment. And if it is 4 to 10, you can again consider the treatment. This is the classical recommendation given by the American Thyroid Society. And even an anti-TPO positive, if the TSH value even less than 2.5, some of the infertility specialists like Raju sir, they may consider treating the patient. Because in the future, this patient can develop an other autoimmune diseases, means it's like thyroid is like that. When even after delivery also, the patient go into thyrotoxic crisis, you can go for a transient period 3 months, because whatever the available the thyroid hormones that can be released immediately into the circulation, that also can happen. There don't treat with the propyl thyroxine and methyl thyroxine. These patients should be treated with a beta blocker only. Don't do it, because basically it is not a hyperthyroidism. Whatever the available thyroid hormones which is present in the glands, it is immediately released. That is autoimmune thyroiditis. Anti-TPO antibody is very, very important. So concluding the talk, This is a very, very important topics as far as the physicians are concerned. Just I have mentioned what is the target to be taken, and Indian guidelines says all the people with first trimester, anybody comes to you, you do a TSH value, and the Indian guideline says TSH value, keep it below 2.5. And whenever you are treat with a full dose, and always you ask for a anti-TP or antibody when there is a TSH is between 2.5 to 5 to 10. Thank you.
Thank you, Sadak sir, for an excellent talk. It's a very lucid, clear, starting from the basics to the intricacies. And the must point to be highlighted is a matter-of-fact talk. So, as sir rightly pointed out, hypothyroidism in pregnancy, now as a fertility specialist, we do cater the more importance to the preconceptual care. Because when the patient gets into pregnancy with a bad thyroid state, obviously the outcome can be bad. So when we are dealing with so much recurrent pregnancy losses, miscarriages, and then finding out the patient is having hypothyroidism, so the implication is something called preconceptual care, making the lady in a better environment to conceive. So thyroid is an important tool in the preconceptual care, and the Indian thyroid guidelines was been endorsed by our Gynec Society, FOXY. That is why the first trimester routine screening for all pregnant ladies with TSH. And the topic is open for discussion, and I will initiate some questions. Sir, it's a common doubt for majority of the obstetricians once the patient is put on with thyroid supplementation. How you monitor the patient in 6 weeks interval with TSH alone, or TSH with T3, T4, or TSH with FT4?
Guideline says everything is based on the TSH. Guideline says you keep the TSH below 2.5 or below 3 first or second trimester of the pregnancy. That guideline, even American guideline also, doesn't mention about the T3 and T4, but when the postpartum period, they are mentioning about the value of T3 and T4 to rule out a thyrotoxic crisis.
So we do somehow come up with a situation that the TSH will be normal, but the FT4 will be quite high. So we'll be in a little dilemma that whether just reduce the dose or not. What is your talking about?
That is situations are there. That is a hyperthyroxemia, where TSH is normal. It's a very rare situation as such. That's what I came to know. There, when the thyroxine levels goes up, I think you have to slightly reduce the dose. That's what.
Any questions?
Sir, compared to our Indian physicians, what guidelines we are following, what you told. Okay, is there any data for complications who has followed American Diet Society?
The American data has come after 2017. 2017 guideline says, I just opened the topic like that things, what the Indian guideline and the American guideline. You can follow any of the things, but they keep the target, both the target. Diagnosis, this is the only that coming to the diagnosis. So finally what I have shown is the ATA guideline only. And now we are following that only. That is the ATA guideline says. So that is why it has come in 2014, I think.
Yeah, it is in 2018.
No, previous guideline.
14.
It was come in 2014. That
Yeah, so basically, as rightly pointed out, there are actually in the last decade, last 4 or 5 years, there are some studies which came up not showing an improvement, deteriorating the neurological development of the baby. Because previously, that common issue in treating a thyroid condition in pregnancy, telling that the patient IQ will be a little bad. But there are some studies proving that it is not doubt. But the problem is that there are a lot of other pregnancy-related complications like IUGR, preterm birth, neonatal complications has been associated with the hypothyroidism in pregnancy. So whether this may attribute to a further neurological sequelae is yet to proven.
So since the pregnancy is a difficult condition, we have to treat the baby as well as the mother. It is always to have a better control of thyroid during the pregnancy stage, so that avoid complications can be prevented at a later stage, even though the present evidence is lacking on it. Yeah. So actually, Sir has already shown a slide regarding that, because one study he quoted is actually an Indian data on the prevalence of IUGR, the prevalence of PIH, and the neuropsychiatric development. So there is an Indian data prevailing to this also, because the Indian Thyroid Society guidelines has been endorsed by the FOXI. FOXI is the organization of the Gynecological Society of India. So there has proven drawback of hypothyroidism in pregnancy. I think I'm clearing your doubts.
In fact, regarding the neurological complication, in US there was a study conducted. What they done was, they take the umbilical cord sample and they keep it for a period of 10 years. After 10 years, follow up these people, then only they found that the subclinical hypothyroidism patient, the normal people has approximately 107 is the IQ, and those people who had a hypothyroidism, because they can, from the umbilical cord, you can check that amount of thyroxine in the TSH in these people. And they found that those people who had a subclinical hypothyroidism, this is done after 7 years, they showed a 7 point down the IQ in these people. Okay.
Wind up the session, thanks.
I'd like to invite Dr. Rajiv Mohammed to present a moment.
Sir, one more. Sarin.
In fact, there is a recommendation also like that thing. But when this simple thing is that if the patients usually comes and ask, when you miss the dose, sir, I forgot to take in the morning sample, can I take in the afternoon? Or can I take in the night? To tell these people, even there is no complication, even if you combining or 2 or 3 days, that there is a recommendation is there. There is a recommendation is there. There's no doubt. Sharma sir? Okay.
Dr. Rajiv Mohammed to present a memento to Dr. Sadakatullah sir. Dr. Anthony George Joseph to present a memento to Dr. Raju R. Nair. And Dr. Annama, HOD OBG KIMS, to present a memento to Dr. Rajiv Mohammed. Our last talk for the day will be when and how to treat hyperuricemia. I'd like to welcome the speaker, Dr. Abraham Mohan, consultant rheumatologist in Caritas Hospital, and chairperson, Dr. Hari Krishnan G, consultant rheumatologist in Kottayam Medical College, and Dr. Anil Matthew, consultant physician in KIMS Hospital, Kottayam.
Okay.
Good afternoon. We are coming to the last topic of the day. That is hyperuricemia is a common problem we face during our clinical practice. Hyperuricemia or high uric acid is usually a common problem. When and how to treat hyperuricemia is our subject. Hyperuricemia is part of our problem. when the high uric acid levels occur, deposit in our body, or if it is not excreted properly from our body, the purine levels will get increased. So usually it's nowadays we consider as a marker for metabolic syndrome also. Hyperuricemia comes as a marker for metabolic syndrome, or it can be a part of our chronic kidney disease or high purine levels, food diet, etc. So today we have an eminent speaker for that. He is a friend of mine, Dr. Abraham Mohan. He is a rheumatologist in Caritas Hospital. I will hand over to our chairman, co-chairman also.
Good afternoon, everyone. So hyperuricemia, as sir rightly told, is a very commonly encountered clinical problem. And is it required to treat all patients with hyperuricemia, or is there a subgroup of patients where we can observe them? So that is the question today. So to talk on this topic, we have Dr. Abraham Mohan, who is an established rheumatologist. Without wasting in time, we will get into the topic.
Good afternoon, everyone. My thank at the outset, Sadak sir and KIMS academics for this opportunity. And this topic, hyperuricemia, we often get a lot of references, patients with symptoms related to arthritis and not sometimes. And I approach this talk more as a physician because, I've gone through literature sort of not only related to arthritis, also impact on other systems. So first we'll start off with how do we classify hyperuricemia? So symptomatic and asymptomatic. Symptomatic is accompanied by symptoms of gout, urolithiasis or acute urate nephropathy. And asymptomatic is increased serum uric acid level without the above mentioned symptoms. So it is known that elevated serum uric acid levels may cause silent tissue damage, and these patients can have an increased risk of hypertension, dyslipidemia, obesity, metabolic syndrome, diabetes, cardiovascular disease, chronic kidney disease. And hyperuricemia is a prognostic marker of mortality in stable coronary artery disease patients with percutaneous coronary interventions, patients with COPD, terminally ill cancer patients. Even hyperuricemia in critically ill patients in ICU marks as an early marker of severity of sepsis. It's a predictor of acute kidney injury, acute respiratory distress syndrome, and need for mechanical ventilation use and mortality. So hyperuricemia can be used as a prognostic marker in many conditions. So to understand the treatment and how it works, it's important to know how the origin of uric acid, its metabolism and its overall role. So it's a weak acid which is generated as a final product of metabolism of purines. Majority is generated endogenously. That is 500 to 600 milligram per day. That is from nucleic acid breakdown and de novo purine biosynthesis. And we get source from exogenously from diet also. That is 100 to 200 milligram per day. Battery is okay. Battery low. Plug in. So diets rich in purine, organ meats, anchovies, legumes, sardines, yeast and beer are rich in purine, and even increased consumption of fructose-rich products. These intensify ATP degradation, and it leads to increased uric acid production. So the main enzyme which is responsible for catalysis of purine to uric acid is xanthine oxidase, and its highest concentration is in the liver, which is a major organ of uric acid production. So uric acid is the final product of urine metabolism in humans, whereas in other mammals, the final product of metabolism uricase, which final product of metabolism is allantoin. There is an enzyme called uricase which helps in the breakdown of uric acid to allantoin, which is easily excreted in urine. So it's believed that in human beings, the uricase coding gene was lost in the evolution of humans, and that's why we don't have uricase like other mammals. So, and there is a functional importance for that. Higher uric acid levels helps to maintain higher blood pressure, and which helps in maintaining an upright posture, and also helps in the conversion of fructose in fruits, conversion to fat, which is helped by loss of uricase. If uricase was present, probably we could not have utilized in that way, fructose conversion to fat. So uric acid has different properties. It works as an oxidant, antioxidant, depending on the microenvironment. It's a strong antioxidant, and it could have a neuroprotective role, and it has an importance in development of human intelligence. Uric acid could extend lifespan and reduce cancer risk in humans and higher primates. It is linked to a higher bone mineral density. So these are its antioxidant properties. Now its pro-oxidative activities. It leads to endothelial injury, leading to hypertension and cardiovascular disorders. And a disruption of oxidative balance inside the adipose tissue can lead to higher risk of metabolic syndrome and insulin resistance. Renal ischemia can occur due to decreased nitric oxide levels and increased local vasoconstriction. So, kidneys play a major role in maintaining the uric acid metabolic balance, because hyperuricemia is caused by inadequate renal excretion in 90% of the patients, and excess production it's only in 10% of the cases. Kidneys eliminate about 2/3 of the uric acid produced daily, and the remaining 1/3 is excreted through the digestive tract. The 90% of the filtered uric acid load is reabsorbed by the renal proximal tubules, and it's one of its important physiological functions. So, renal absorption of uric acid involves several transporters like URAT1 and that is urate transporter 1 and glucose transporter 9, and the function of these are influenced by a number of factors like genes, drugs, increased serum lead, lactate or ketone concentrations. So this is a flowchart which shows, this summarizes the whole thing: hyperuricemia, uricemia, inadequate renal excretion 90% of the cases, overproduction 10% of cases, and the various causes as I told. So when do we use urate lowering therapy in gout? So gout affects about 1/3 of the patients with hyperuricemia, and it's only correctly diagnosed in 2/3 of the affected subjects, and it's only properly treated in half of the diagnosed patients. So the proportion of patients actually having hyperuricemia treated are only a small proportion, and the pathophysiology is uric acid crystallization and subsequent mechanical and chemical irritation of articular tissues, and this leads to inflammation of joints and soft tissues, as well as generation of tophi made of uric acid deposits. So now let's just run through the guidelines which we have. The American College of Rheumatology guidelines came in 2012, which was updated in 2020. We have the 3E guidelines, evidence, expertise and exchange guidelines, and the EULAR, European League Against Rheumatism recommendation 2016. So first I'm just telling the similarities between these guidelines. All guidelines, these 3 guidelines generally recommend start treatment within 24 hours. For symptom control, first give colchicine or NSAIDs or glucocorticoids, which are the first line agents. Start urate lowering therapy only after the acute gout phase. However, if urate lowering therapy was started before acute episode, it can be continued. This is a common mistake that we see when first time patient comes with an episode, not first time or maybe a third episode. The first time the drug is started when an acute episode happens. So generally what happens is patients flare that time. If you start urate lowering therapy, first symptom control is most important. So use long-term urate lowering therapy only in selected cases. That is, patients who have tophi. Tophi are collection of uric acids, which is seen subcutaneously. In few patients you can see around the ears, some around the elbow. I don't have a picture, I should have put. And also in chronic gouty arthropathy, these patients only urate lowering therapy should be started immediately. Use allopurinol, febuxostat and probenecid as first line agents and pegloticase as a second line drug. So start allopurinol at a low dose and then gradually escalate to a minimal effective dose. Monitor uric acid levels during urate lowering therapy. Treat to target until all symptoms are resolved and uric acid target levels are achieved. Maintain a uric acid target level lifelong. We know throughout the world uric acid or gout patients suffer because of the poor compliance. Once their symptoms are controlled, then they go back to their old diet and old patterns. And that is why it's across the globe. We see that these patients, they come again and again to the OPD at some intervals. So it's important to consider secondary gout prophylaxis with colchicine or NSAIDs and also screen for comorbidities associated with hyperuricemia. Now these are differences between the guidelines. There are minor differences. What is the maximum colchicine dose used? 1.8 mg according to the American College of Rheumatology, 3 initiated 2 mg, ULR 1.5. Generally, tau-5 is an indication for urate lowering therapy, more than or equal to 1 tau-5. And radiographic damage of gout more than or equal to 2 episodes per year. These are all common among the guidelines. Only the American College of Rheumatology, they insist like conditionally in starting uric acid lowering urate lowering therapy in stage 3 to 5 CKD, that is chronic kidney disease or nephrolithiasis, or uric acid more than 9, or infrequent recurrence, that is less than 2 episodes per year. The dose of allopurinol started is generally between 50 to 100, and you can escalate the dose of uric acid every 2 to 4 weeks. There are minor differences. Generally, the uric acid target level is aimed at around less than 6 and is less than 5 in the case of chronic gouty arthropathy or the presence of tau-5 in 3 guidelines and ULR. In ACR guidelines, they consider giving the secondary prophylaxis. Usually we give colchicine, that is around 3 to 6 months. Other guidelines varies. In 3, it's based on physician judgment. ULR up to 6 months. So in patients with previous gout, sudden intake of high purine can lead to gout recurrence almost 5 times. So this is what happens. Will be well controlled patients start eating beef, mutton and all these high purine diets and they develop a flare. So what are the dietary changes which are beneficial for gout patients? One is decreased intake of red meat, alcohol, especially beer, and sugary beverages. Increased coffee consumption is beneficial, and all patients generally who are overweight or obese, we recommend weight loss. Weight loss should be gradual in order to avoid ketonemia-induced gout crisis. Otherwise, they can develop gout while rapid weight loss. So dietary interventions always add supportive to the urate lowering therapy. Only giving dietary interventions are not effective. Urate lowering therapy is the first treatment choice and dietary interventions will help with them. It's essential that they take urate lowering therapy because we know primarily patients suffer gout because of decreased excretion of uric acid. So only giving dietary interventions won't be effective. Even medication should be there. So what are the pharmacological interventions? The first line drugs, xanthine oxidase inhibitors are the drug of choice, allopurinol or febuxostat. These are drugs which block transformation of uric acid precursors to uric acid. The allopurinol is a purine selective xanthine oxidase inhibitor. The starting dose is less than or equal to 100. In selected population, including Southeast Asian or African American, testing for a HLA B5801 should be considered. Otherwise, sometimes they can develop severe side effects like DRESS syndrome, which is a potentially life-threatening drug reaction with eosinophilia and systemic symptoms. Other reactions which can occur are rash, pruritus, cytopenia, diarrhea, toxic epidermolysis, and Stevens-Johnson syndrome. So in Southeast Asian patients, we should be a little careful of starting allopurinol. Start at a low dose, usually around 100 mg. Never start on a higher dose. And use of allopurinol in standard doses may cause renal failure progression in pre-existing renal insufficiency. So even in patients with renal deficiency, it's better to start at a lower dose, maybe 50 or 100 mg. Be careful. This happens because the renal clearance of oxypurinol, which is a major metabolite of allopurinol, is directly proportional to the renal creatinine clearance. So, when the renal creatinine clearance goes down, oxypurinol excretion will be reduced from the body. So, as I told, in order to prevent life-threatening toxicity, it will be better to start a dose of around 50 mg per day in patients with low creatinine clearance. Now, the other common drug which uses febuxostat, it's a non-purine selective inhibitor of xanthine oxidase, and it can be prescribed in allopurinol inefficiency or intolerance. And the recommended starting dose is 40 to 80 milligrams per day. General side effects which I see is mild transaminases elevation. Now, the next group of agents which can be added to the xanthine oxidase inhibitors are uricosuric agent, and this can be used to achieve a therapy target, that is complete resolution of symptoms including tophi and a uric acid target level. It can be used as a monotherapy or added to a xanthine oxidase inhibitor, as I told, and it works by increasing uric acid renal excretion by inhibiting the urate transporter 1 in renal tubules. So it's important during uricosuric therapy we have an increased fluid intake which reduces the risk of urolithiasis, because it primarily works by excreting more uric acid through the kidneys. Otherwise urolithiasis might develop, and it should be avoided in patients with renal calculi or stage 3 to 5 chronic kidney disease. It is the most commonly used. Probenecid is the most commonly used uricosuric, and dose is 500 milligram once or twice daily. And the dose should be titrated in order to achieve the target. Lesinurad is a novel uricosuric drug developed in 2016, but it's not still using in India. It's more potent and effective in moderate renal insufficiency compared to probenecid. Dose is 200 milligram per day in addition to allopurinol or febuxostat, and can be used in case of xanthine oxidase inhibitor inefficiency to achieve targets. Higher doses are not recommended, that's around 400 milligram a day, because there can be associated rise in creatine levels. Arhalofenate is another agent which is also yet to come into the India market, but it's a peroximum proliferator activated receptor gamma partial agonist, and it inhibits the URAT1 organic anion transporter 4 and organic anion transporter 10, as well as IL beta expression. And it has an anti-inflammatory as well as a uric acid lowering effect. Anti-inflammatory effects help in prophylaxis, like it prevents in further effects coming, further flares coming, like colchicine does. But it's a weaker anti-inflammatory compared to NSAIDs. Now, uricases are the next group which used in severe and recurrent gout, and it's given parenterally usually. And it has a risk of infusion reactions. There are two molecules which you have, rasburicase or pegloticase. Pegloticase is the pegylated form. This is a second line drug, and it should be only administered as a monotherapy in case of inefficiency of first line drugs like allopurinol or febuxostat or probenecid. And prolonged use may be associated with the production of anti-drug antibodies and thus decreasing their efficacy. Now, how do they work? Now, that's what I told why uricases are important. That's why I mentioned synthetic uricases help transform the uric acid to allantoin, which is a easily excretable product, which can be excreted in the urine easily, just like in other mammals. So, in cases where the first line drugs don't work, pegloticase or rasburicase is an option. And in severe cases, it should be considered. If there is an inefficiency or intolerance of uricases, we can use the monoclonal antibodies like anakinra or canakinumab, which is an IL-1 inhibitor. This also is not freely available in the Indian market. We have to import it, so it's very costly also. And it should be only given after excluding infections. In secondary prophylaxis, commonly drugs which we use are colchicine and NSAIDs, and this can be considered in patients with asymptomatic hyperuricemia, but it differs in terms in suggested prophylaxis duration. NSAIDs we know we don't give for prolonged periods, and colchicine generally 3 to 6 months we give. And colchicine is contraindicated in patients with potent CYP3A4 inhibitors or P-glycoprotein inhibitors who are taking these drugs because there is high risk of drug interaction. Patient on long-term colchicine therapy, they should be, checked for their baseline renal dysfunction or concomitant statin treatment because it can lead to neurotoxicity and myotoxicity, which are the side effects of colchicine, and can happen because of decreased elimination in the case of renal dysfunction, or sometimes statin myopathy, statin side effects might occur because of the interaction with colchicine. So this is also a summary sort of, whatever I told till now, the mechanism of action. Cypoxanthine is converted to xanthine. Xanthine oxidase works here, and even from the conversion from xanthine to uric acid, febuxostat and allopurinol inhibit there. Uric acid to allantoin conversion is helped by uricase, and uricosurics help with the excretion. So these are the molecules which I just spoke about. So it's important to screen for comorbidities in gout. We know that gout patients generally they develop other comorbidities like obesity, diabetes, hyperlipidemia, hypertension, metabolic syndrome. Whether they are genetic and dietary factors, alcohol or overuse, cardiovascular risk factors, chronic renal disease, nephrolithiasis, psoriasis, lead intoxication, lympho and myeloproliferative disease, and use of some drugs. So these are all risk factors which need to be sort of screened, whether to know whether they are more prone for gout. Most of the time, many times we come across all this when we should take a history whether they have any other risk factors. So there are some drugs which elevate uric acid levels in gout patients, such as loop diuretics and thiazides. And these diuretics, they decrease the uric acid excretion by competing with uric acid for cell membrane transporters and renal proximal tubules. Generally, hydrochlorothiazide should be generally avoided in gout patients if possible. Other drugs which are potentially inducing hyperuricemia, diuretics we already told, salicylates, cyclosporin, 2-ethylamino 1,3,4-thiodiazole, pyrazinamide, ethambutol, nicotinic acid and cytotoxic agents. I'm sure people must have come across many those are taking ATT, antitubercular therapy, developing gout. So all common things we come across. Aspirin, a lot of cardiology patients while on aspirin they develop gout. So ACR generally recommends against starting urate lowering therapy in patients with asymptomatic hyperuricemia with or without comorbidities, based on the low evidence of gout in such patients noted in observational studies. But there is a conditional guideline also, like if the uric acid is more than 9, it may be considered. It depends from patient to patient. So I've just gone through also other comorbidities, hyperuricemia and cardiovascular disease. I'll just run through them. So the causes, clinical impact and treatment of asymptomatic hyperuricemia in patients with cardiovascular disease remains controversial. And this could be due to reduced glomerular filtration rate, renal vasoconstriction, hyperinsulinemia, tissue ischemia, oxidative stress, or diuretic treatment. So elevated uric acid is an independent risk factor of cardiovascular incidence and mortality. And hyperuricemia can also lead to hypertension. This occurs, early onset hypertension mechanisms are uric acid can lead to decreased nitric oxide production and increased creation of reactive oxygen species and renin-angiotensin system stimulation, which in turn leads to renal vasoconstriction and uric acid induced vasoreactive hypertension. So this is the main mechanism. Late onset, it's mainly linked to kidney microcirculation injury, and its direct association with increased BP values is not known actually how it leads to arterial hypertension, kidney microcirculation injury. And these above mechanisms can lead to ischemic heart disease. Of course, it may be also due to platelet aggregation and instant restenosis. And hyperuricemia also has a link to heart failure. Elevated uric acid levels lead to hypoxia, insulin resistance, as well as tissue catabolism, cachexia and sarcopenia. And it's an independent risk factor of poor prognosis, disease progression, and mortality. So heart failure patients with ICD, implantable cardioverter defibrillator, uric acid levels of more than 6.1 may be a predictor of ventricular tachyarrhythmias requiring appropriate ICD therapies. So allopurinol therapy reduces the risk of all-cause mortality and improves the endothelial function and lengthens walking distance in stable angina pectoris. And general opinion based on experts are target uric acid level should be below 6 or it should be below 5 in patients with hyperuricemia and high cardiovascular risk, which are 1 or 2 out of the 6 factors, that is hypertension, dyslipidemia, diabetes, chronic kidney disease, or a history of myocardial infarction or stroke. So all patients with elevated uric acid level should receive a diet, role of diet and physical activity, just like in patients with gout. Comorbidity should be assessed and start at the least, allopurinol should be started at the least dose, that is 100 milligram per day. And if there is effectiveness of low dose allopurinol, go to higher doses, 300 to 600 milligram. Once uric acid is normalized, then ULT should be continued and uric acid should be assessed every 6 months. If therapeutic goal is not achieved, then you add other therapies like uricosurics or resistant cases, maybe pegloticase or raspuricase. So in chronic kidney disease, hyperuricemia, we know it's very common and it may be considered a marker of kidney disease mainly due to its impaired excretion. And whether hyperuricemia itself leads to end-stage kidney disease, there is inconsistent evidence across studies. And it's unclear whether there is an association between higher uric acid concentration and CKD progression and whether a link exists. There is a link, there is a positive correlation between hyperuricemia and diabetes. Both type 1 and 2 has been described. So there are for and against evidence, like in a large cohort study, elevated uric acid level positively correlated with the development of hypertension, but there is no association with the incidence of CKD. But in another review study, elevated uric acid is a predictor of development or not only of CKD and acute kidney injury. So there is no definite sort of evidence whether it leads to CKD. Role of uric acid in acute kidney injury, it's a promising early marker of acute kidney injury. And compared to uric acid, creatinine rises later. So early, like in patients like sepsis and all, maybe we can pick a high uric acid, maybe we can know we'll go into a acute kidney injury. And creatinine levels are influenced by all-cause acertemia and can be falsely low in sepsis. So increased uric acid levels in acute kidney injury result from both increased uric acid production in the course of ischemia and decreased uric acid excretion resulting from decreased glomerular filtration. So there is no clear recommendations whether we should treat asymptomatic hyperuricemia in the context of kidney disease prevention. However, a clinical trial showed a positive effect of allopurinol use on clinical function, that is postponing the twofold serum creatinine level, that is increase the eGFR less than or equal to 50 and the introduction of hemodialysis. So this is delayed by starting allopurinol. So that is one trial, and there is also some meta-analysis by Bose et al. Bose and group that uric acid lower therapy may reduce the incidence of cardiovascular events, which is the most common event of...
Dr. Abraham, we are running short of time.
Okay. It's almost over. So causes of mortality in chronic kidney disease and ameliorate kidney disease outcome. So multiple studies and reviews have shown that urate lowering therapy in hyperuricemic chronic kidney disease should be at least considered, especially in the context of other comorbidities. And uric acid lowering therapy may have a positive effect not only on CKD progression but also on cardiovascular survival and outcome. So I'll just acute urate nephropathy is also is another condition which is linked to uric acid and deposition of urate crystals, and it most often develops tumor lysis syndrome, which is induced by chemotherapy received for myelo and lymphoproliferative disorders. And the plasma uric acid concentration in affected patients is usually above 50 mg per deciliter. The prevention of TLS in cancer patients is the gold standard. Aggressive intravenous hydration and pharmacotherapy, including allopurinol, febuxostat, or aspartate, should be done. And in most severe cases, hemodialysis is the treatment. Chronic urate nephropathy is caused by the deposition of sodium urate crystals in the medullary anesthesia, and workup for conditions causing urine acidification, such as lead poisoning, should be seen. And uric acid nephrolithiasis. Treatment consists of urine alkalinization by potassium citrate or bicarbonate administration and a massive fluid intake. And treatment failure or recurrence of nephrolithiasis, especially in recurrent gout, xanthine oxidase inhibitors are recommended. Urine alkalinization and fluid therapy should not be discontinued after the introduction of xanthine oxidase inhibitor. So, xanthine oxidase inhibitors plus urine alkalinization plus massive fluid intake is the treatment of choice. The last one important thing is asymptomatic hyperuricemia. This is an area there's a lot of confusion when to start the uric acid lowering therapy. So generally, if the uric acid levels are more than 13 in men or more than 10, you should search for cause of hyperuricemia. The 24-hour urine excretion, if it is like less than 1 gram per 24 hours on normal diet, then or you have to classify whether it's less than 1 gram, more than 1 gram. If it's more than 1 gram per 24 hours, screen for renal disease, metabolic causes, or rare genetic defects, and avoid uricosurics. Recommend lifestyle changes and start urate lowering therapy in the absence of contraindications. So, 13 is the cutoff in patients asymptomatic hyperuricemia. If it's more than 13, in the absence of even other symptoms, that is top 5 chronic arthropathy or more than 2 episodes per year, you can start treatment. So this is based on evidence for multiple studies. In other patients where the level in women like 7 to 10 or in men it's 7 to 13, start urine lowering therapy if the history is positive for severe episodes like top 5 collection of uric acid, urate, chronic arthropathy, more than 2 episodes per year, recurrent nephrolithiasis, cancer patients undergoing treatment, and risk of tumor lysis syndrome. Even patients can be considered on urate lowering therapy in patients with high cardiovascular risk, patients with heart failure, and patients with chronic kidney disease. So the slide, most time, this 1 minute. So the febuxostat, the black box rules, blues over there related to febuxostat. In 2019, we know that a black box warning was issued against febuxostat based on a trial in 2018. So initially, a confirmed trial was done in 2010. Febuxostat was considered to be safe in comparison to allopurinol, and it showed that it was more efficacious than allopurinol, and the safety of febuxostat and allopurinol was comparable. Now, what happened in 2018? There's a study published in NEGM by White et al. This is a multi-center trial. Here, what happened was that in patients with gout and cardiovascular disease, 6,190 patients received febuxostat or allopurinol. But in this trial, 57% of the patients discontinued, and 45% patients discontinued follow-up. And what they conclude in this trial was that febuxostat resulted in overall major CV events similar to allopurinol, but it is reported that the cardiovascular death and deaths from any cause was more frequent in febuxostat group than allopurinol. So this created waves all over the world, like febuxostat is not safe in patient with cardiovascular disease. So there are some flaws with this trial. One thing is there is no control arm. Febuxostat was directly compared with allopurinol. And other thing, there is a high dropout rate, like I told. And data was essentially incomplete. So there are some new trials in FREED study and FAST trial. Here, these trials, which are coming in 2019 and 20, have shown that allopurinol and febuxostat are safe, equally safe. Thank you. Okay.
Just a couple of comments actually. One, hyperuricemia is a very common complaint, and hyperuricemia is not equivalent to gout. Okay, so we get a lot of referrals, and hyperuricemia is just one problem. It's basically a tip of the iceberg kind of thing. So when you get hyperuricemia, you have to look for all the things, and the most important cause is metabolic syndrome. So that is more prevalent than gout. And as Abraham rightly pointed out, only less than 1/3 of the patients with hyperuricemia develop gout. So the most common cause presenting to us is metabolic syndrome, and we have seen other causes like myeloproliferative disorders and other numerous causes. And whether to treat or not, in asymptomatic hyperuricemia, there is a school of thought for treating patients who have family history of gout. Like some patients have asymptomatic hyperuricemia with family members affected with inborn errors of metabolism causing hyperuricemia. So those patients can be treated, or asymptomatic hyperuricemia with a TOFI or radiological joint damage, patients with nephrolithiasis. Those patients can also be treated for hyperuricemia.
Thank you.
I'd like to invite Dr. Anil Matthew to present the memento to Dr. Abraham Mohan. Dr. Ajay Kamath to present the memento to Dr. Hari Krishnan G. And Dr. Balakrishnan, Senior Medical Officer, Balakumar, Senior Medical Officer from Caritas Hospital, to present the memento to Dr. Anil Matthew. With that, we'll be winding up with our sessions. I'd like to invite Dr. Nandakumar for feedback and appreciation of the CME.
So I don't want to delay the lunch time. So, but few words regarding my friend Sadakatullah has arranged a very beautiful venue, as well as all the burning topics and the emerging topics were covered, and we are very lucky that eminent personalities of our healthcare profession like Dr. Sharma, Dr. Sukumaran and all have come and enlightened us on the topics, and it was very fruitful. And of course the questions and session was also given, and depending on the time the speaker has taken. So that was also very encouraging, and the feedback which I would like to say is that and also this online platform was also arranged so that those who could not come to the present session can enjoy the knowledge being spread through the YouTube. I think it was through YouTube it was done. So that also is a unique thing in our this type of seminars, and we look forward for the further this type of seminars in the coming future from the KIMS Academy. So I thanks for all the opportunities which is given as a CME program. Thank you very much.
Thank you, Dr. Nandakumar, for your appreciation. Now, I would like to take this opportunity to give a vote of thanks, propose a vote of thanks on behalf of the KIMS family, and in my capacity as the chairman of the Clinical Excellence Committee of KIMS. First of all, I would like to congratulate our Dr. Sadakatullah for the excellent way of, because he is the one man behind the show, and so that I take this opportunity to congratulate him, and I would like to place on record our sincere thanks and appreciation to all our great speakers and especially those who are present here. I just in mentioning names for paucity of time. Dr. Unni, Dr. Venugopal, Dr. Dr. Eba Mohan, and all our faculty, all our chairpersons who excellently modulated the sessions, and lastly but not the least, all of you who have made it a resounding success. And also, I would not be fair if I don't place on record our sincere appreciation to our Dr. Celine, who is Arikart, who is also our associate member, because she is the better half of our surgeon, Dr. Irene. And then our CEO, Mr. Prakash, and our chairman, Dr. M.I. Sagadullah, whose patronage and encouragement has also always been a beacon of light for us. And lastly but not the least, Mr. Asif, who has efficiently conducted the audio visual sessions, and then our HR assistant manager, Miss Ashley, and Mrs. Rinsi, our better half of our CEO, Mr. Prakash, and Mr. Girish, who has also, has been the, very important person behind the audiovisual presentations, and especially the airing of the our YouTube sessions. And thank you all once again on behalf of KIMS family. Please cooperate with us in our future endeavors also, because this is the fifth one, and we will be coming up with new sessions, and your most suggestions are always welcome anytime. Thank you. Please join us for lunch before you go.